So that's the reason I thought that Okinawa is a good place to start a network among Asian countries and area. I proposed the idea to the Professor Carrió, representative of Hope Asia Network, as well as Vice President of Japanese Society of Hypertension, the plan to have this Asian communication meeting. He kindly agreed and helped to build this session. Furthermore, Professor Nishiyama, a chairman of the International Committee of Japanese Society of Hypertension, and Professor Rakugi, a president of Japanese Society of Hypertension, also agreed and support very much to this session. The program, this is today's program. Part 1 include overview lecture and 5 mini lectures for share the current status of hypertension and hypertension-related diseases. Part 2 include network conference to know present status of hypertension control in Asian countries and to standardize the evidence-based hypertension management in Asia. Because of COVID-19, we could not meet directly, but let's communicate on the web. Enjoy this meeting. Thank you. Okay, so let's start this part 1 session. First of all, I'd like to introduce Dr. Carrió. Dr. Carrió will have an overview lecture. All of you know Dr. Carrió very much, so I may skip his my title and introduction, but I actually respect him very much to start this kind of international communication, especially in Asia. Now I call Dr. Carrió. Title of his over-lecture view is Goal for Zero Cardiovascular Events in Asia, focus on the management of hypertension. Dr. Carrió, please.
Hi. Good morning, ladies and gentlemen. I'm Kazumi Carrió. I'm very pleased to have this session. I admire Dr. Oya because he has an enthusiastic person with the good leadership, with extreme passions. So I'm very pleased to have initiate the new stage of the Asian direction for the management of hypertension. So let me start my talk. Could you see? Could you see and hear?
Yeah, yes.
Okay, so okay, let me start the goal of zero cardiovascular event in Asia, focus on the management of hypertension. So today, the 12 Asian countries and regions, we are pleased to have make the association with together the hypertension society levels. So all the different countries within the same Asian gathered together. So we have several meetings before this, the Let's Overcome Hypertension and the hypertension-related disease in Asia. So today, I would like to refer to these 3 topics. How important the strict blood pressure control, especially in Asia. The second, how important we should use the home and 24 blood pressure management for blood pressure. Third, zero cardiovascular event management by hypertension management. So this shows the age-related standardized cardiovascular death ratio. As shown here, the Eastern Asia here, the Malaysia, Indonesia, and Thailand, this is a stroke death ratio, age adjusted. So compared to the Westerners, we are almost all we have the increased incidence of stroke deaths. And coronary heart disease deaths, as shown here, the Malaysia, Indonesia, and Thailand, the increased. But Eastern Asia, compared to the Westerners, we are almost the half. So there are significantly the country difference in the demographics of cardiovascular disease in each country levels. But especially blood pressure, its impact is greater in Asian countries. As shown here, this is office blood pressure. The increase in the systolic blood pressure by 15 millimeters of mercury, it accounts for 1.5 times the stroke risk in Westerners. But in Asians, it increased the risk 2.5. Also, this difference remains significant for the coronary artery disease. So, impact of the increasing the blood pressure is greater in Asian countries. So we have the very important factors contributing hypertension and related disease in Asia. Asians have the increased salt sensitivity and the increased salt intake. Obesity and the diabetes and metabolic syndrome is dramatically increasing because of the Western lifestyles. And also we have the seasonal variation and the air pollution and dietary and the urbanization. These are very big problem recently. And we have the blood pressure variability characteristic in Asia. So these are the factors we should reduce. So from now, I'd like to introduce some recent important evidence from the Asia. So this is a STEP study. So STEP study is evidence on the older hypertensive patient. They divided the intensive treatment group targeting the systolic blood pressure 110 to 130 for office blood pressure. And the standardized group is between the 130 to 150. So as shown here, this is a standard group. Here is the intensive group. This difference was 9.3 millimeters of mercury. This is the office blood pressure difference. And here, also in Asia, we are focusing on the morning home systolic blood pressure levels. This shows the difference in the morning systolic home blood pressure levels. Between these two groups, there are significant difference. It's around the 7.5 millimeters of mercury. So these office and the home BP difference will account for the difference in the cardiovascular outcomes. The primary outcomes was shown here. Hazard ratio was 0.74. So 26% reduction was found in the intensive treatment group from the beginning to the end. This is a total cardiovascular disease. But when we see the component of the demographic of the cardiovascular disease, as shown here, the atherosclerotic cardiovascular disease, ASCVD, stroke and coronary artery disease, hazard ratio here, the 33% reduction was found. But markedly, the benefit of the strict blood pressure control was found in the acute heart failure. So hazard ratio was to 0.27. So 73 reduction was found. So this reduction was 1.8 times benefit compared to the sprint trials. So we have the more benefit in compared to the Westerners by strict blood pressure control. And also salt substitute reduction by the 25%, reduced stroke risk by 14%, non-fatal acute coronary syndrome by 30%, and death for these values. So salt reduction should be effective in Asian countries. So this showed also another important evidence which demonstrate how important the digital therapeutics of the hypertension management in Japan. So here, using the application of the smartphone, is introduced to these 6 non-pharmacological interventions: salt intake, body weight reduction, and exercise, alcohol reduction, and stress management and sleep condition improvement. So digital therapeutic program introduce these good behaviors by the patient levels by smartphone, reduce blood pressure reduction. So as shown here, this is a primary outcome of the first trial of digital therapeutics in hypertension field. That this shows the control. Control is only monitoring home blood pressure. And this pink bar shows the digital therapeutics using the smartphone. As shown here, primary outcome was the minus 2.4 millimeters of mercury reduction was found. And very importantly, this difference was the market for the reduction of morning home systolic blood pressure. As shown here, 10 millimeters of mercury reduction was found. The home control group also reduced 6.2. It's due to the self-monitoring, the biofeedback, and also general the introduction of the non-pharmacological treatment by pamphlet. So difference was 4.3. So clearly, the non-pharmacological treatment is important in Asian patients. This is drug-naive patient. So this shows the salt intake score developed by Dr. Tsuchihashi. So we are Japan, it's very popular self-reported salt intake. As shown here, reduction of the salt intake score or market in the digital therapeutics group compared to the control group. So this reduction, degree of reduction, was the partly account for the reduction of the morning home blood pressure by the individual levels. Second, how important home and 24 blood pressure control. Second topic. So this showed our prospective study, the general practitioner-based, the nationwide prospective study. Clearly demonstrated how important morning blood pressure control compared to the evening home blood pressure. compared to the well-controlled group less than 135, when the morning home blood pressure increased above the 135, it increased the risk 2.5 for stroke events, then gradually increased. Evening blood pressure levels, compared to the morning, so it reached after 165. So you can see how important morning blood pressure management, especially in the medicated patient. In this population, almost the patient were medicated by antihypertensive treatment. So blind spot is a morning blood pressure. We should reduce morning blood pressure, especially in the medicated group. And also, this is the latest evidence from our J-HOP study using the home blood pressure. We measured the 14 days, or 3 times morning and 3 times in the evening. Then the max SBP was the highest 3 average of the home systolic blood pressure. As shown here, the highest quintile, it's above 170. Red showed the increased risk of stroke, independently increased the risk 10 times compared to the well-controlled, always reduced less than 140. Compared to these values, the maximum SBP, 10 times risk, even after controlling for the average, and also the blood pressure variability, CV. So usually we excluded such a maximum SBP, but such a big, probably it's a surge, component of the surge blood pressure should be important as a trigger of cardiovascular events, especially in the stroke. It's a first evidence. And this shows the resonance hypothesis of blood pressure variability. The blood pressure surge peak consists of the different blood pressure variability with different time phases. Longest phase is a yearly change, second seasonal, day by day, and diurnal, and beat by beat. That this beat by beat is triggered by such triggers, exercise, mental stress, or PM 2.5, or such a cold temperature trigger such a peak. So synergistically, the peak was exaggerated. So it's a dynamic surge. It should trigger cardiovascular events. We should reduce the average level, but also reduce the peak. To reduce the peak and the morning blood pressure is especially important for the high-risk patient. We stratified the study subject, hypertension medicated patient, into the 3 groups: low and medium and the exaggerated high-risk group. As shown here, morning association with the morning SBP increase was the marked exponential shape. The association was found with cardiovascular events. So the higher risk, more eccentrically reduced, especially in the morning blood pressure, compared to the intermediate and low risk. Because the blood pressure high risk stiffened artery exaggerated the morning blood pressure variability. It's a concept of the systemic hemodynamic atherosclerotic syndrome, SHATS. It's a coupling the vascular disease and blood pressure variability. So this vicious cycle will exaggerate the vicious cycle of the cardiovascular disease and trigger cardiovascular events and advance the end organs. This show the not moved. This show the pulse of the pulse wave of the softened artery. That it's a stiffened artery. So from here to here, these areas are the cardiac the overload to advance the left ventricular mass. That it's a important the most important organ damage of heart failure, and also this status, the softened artery, is important for the for stroke, because the stroke, if the softened artery, it's absorbs the power of pulse here, but the stiffened artery couldn't absorb the power of pulse. So power of pulse transmitted to the brain to trigger the hemorrhagic stroke or advance the stroke, atherosclerotic stroke, and also advance the CKD. So this is the first barrier against the effect of the pulse. So status of the stiffened artery, especially for large artery, is important. It's a first barrier of the against the hypertension. Also, stiffened artery, it's evaluated by the CABI. So CABI precedes the development of the hypertension, and it's a cardiovascular events indicator of the in hypertensive patient. So in this the prediction model using the deep learning, we make the very good the prediction model of the by using the CABI index and the deep learning XGBoost. So stiffen precedes the hypertension, and it trigger risk for cardiovascular events. And this is a SHATS analysis. So what's the SHATS analysis? It's divided to the study subject into based on the arterial stiffness. So it's this is a data of JHOP, as I mentioned. We divided into the study subject into the softened artery group by PWV and the stiffened artery group. As shown here, increase the blood pressure variability, increase the level of NT-proBNP. It's a stress marker of the strain to the vessels during the systolic phase, especially, was the increased markedly in a patient with stiffened artery. So impact of the blood pressure variability is exaggerated in the patient with the stiffened artery to the against to the cardiac overload. So stiffened artery patient, should be blood pressure levels and the variability should be reduced more extensively. So this is a strategy of the blood pressure management using the home blood pressure and the ambulatory blood pressure. First, using the home blood pressure, we should reduce the blood pressure. And then it's not perfect. ABPM is the important for the cardiovascular zero event. So this shows the impact of the true resistant hypertension in ABPM population study registry, JUMP study. So as shown here, we defined the resistant hypertensive patient, who are other uncontrolled for 24 blood pressure level, systolic 130, even medicated with 3 drugs, including diuretics, as shown here. Compared to the uncontrolled and should resistant hypertension group, should mean the office blood pressure is high, but the 20 blood pressure level is low. Compared to these groups, the uncontrolled, the true resistant hypertension group exhibit that 1.66 times the hazard ratio of the cardiovascular events. Especially it increased in heart failure. So blood pressure control based on the ABPM is important. And also ABPM could detect the blood pressure profile, the phenotyping based on the blood pressure variability. Because in Asia, the morning surge and also nighttime isolated nocturnal hypertension is the more prevalent compared to the Westerners. So this is our first study, morning surge, especially the top 10 percentile. Exaggerated morning surge exhibited increased essential infarction detected by brain MRI, and the follow-up, the stroke risk was the 2.7 times higher than adequate surge group. And also here, this was also again validated by the more larger database with the longer follow-up by Yan Li and Jigan Wang team. As shown here, exaggerated surge using the same definition and exhibited increased total mortality compared to the well-controlled group, and the cardiovascular events are also higher than well-controlled group, or adequate surge group. So this shows the ethnic difference in the degree of morning surge. It's a Artemis study. It's a comparison study between the Japanese and the Spanish and the Italian group. As shown here, the European group did not increase the morning surge according to the age. But in Japan, the gradually increased by age, and independently of the age, the Japanese group exhibited increased the morning surge. So all Asians should have increased the morning surge compared to the Westerners. So this shows our ABPM registry. So which show how important nighttime blood pressure during the follow-up period. It's nationwide practitioner-based study. So nighttime blood pressure, 20 millimeters of mercury increase account for 21% increase for ASCVD and 36% for heart failure. Compared to the daytime, the nighttime risk was higher in this registry. And also very importantly, that it's a nighttime blood pressure phenotype. Riser pattern exhibited the increased risk independently of the average of 24 blood pressure compared to the extreme dippers and dippers. When we separate well-controlled group and poor controlled group, especially the impact of non-dippers and risers was increased in the well-controlled group. Uncontrolled group, there are not so much difference among these 4 groups. So first, importantly, the 24 blood pressure reduction it's the first, the most important. And even well-controlled 24 blood pressure average, it's not enough. Then we should check and control the nocturnal hypertension. So Asians are likely to have isolated nocturnal hypertension compared to the Westerners. It's GIAN-1's the study. So here, the third topic is zero cardiovascular events. So this is the first study with the GIAN-1, the calcium antagonist, the under 24 blood pressure, compared calcium antagonist with the other drug, RAS inhibitors. The closed line is the calcium antagonist. The dot line exhibit RAS inhibitors. So as shown here, the blood pressure reduction, its degree is depend on the baseline BP levels, especially for calcium antagonist. But here, the RAS inhibitors will the other components, such as salt intake and salt sensitivity, will affect. So this slope difference was marked, more increased in the nighttime. So nighttime blood pressure, it depends on the salt intake and salt sensitivity status, but the calcium antagonist doesn't matter. There its blood pressure lowering effect for both daytime and nighttime. So nocturnal blood pressure reduction, these drugs which associated with the sodium reduction will already reduce nocturnal hypertension, preferentially to reduce left ventricular hypertrophy and the CKD, resulting in the beneficial effect for heart failure. So this is the MR blockade effect, as shown here, nighttime reduction. And also the SGLT2 reduce, especially for Japanese, the American Africans, and Westerners. Its blood pressure lowering effect may be increased in the high salt and high intake and high salt sensitivity groups. And this is a reduction of the 20 blood pressure levels, especially for the nighttime by ANI. And this is a reduction of the renal denervation, especially for it covered not only daytime, but it covered nighttime and morning. So achieving the perfect 24 blood pressure control is important. First component is 24 blood pressure levels. Second, circadian rhythm. And third, the blood pressure variability. When we achieve these three components, quality and quantity levels, that we can see the zero cardiovascular events. So ladies and gentlemen, this is a conclusion. The early achievement of the perfect 20 blood pressure control is important. So its benefit should be greater in Asian. So we should consider the ethnicity and barriers for each country levels. Long-acting drug, calcium antagonist, without it's independently of salt status. And also salt releasing strategy is important in Asia. New options such as renal denervation, digital therapeutics, and new drugs such as ANIs, SGLT2, and MR blockers will contribute to management of hypertension. Thank you very much for your attention.
Thank you, Dr. Carrillo, for the wonderful lecture. If there is a comment or a question, please speak directly or write a chat to the chat or something, please. Oh, is there any comments or question? Okay, now I will start the question, Dr. Carrillo. You stressed the importance of perfect 20-hour BP blood pressure control and also the characteristics of the Asian-specific pattern of cardiovascular disease. And I have one question about the Asian characteristics. So you show that the several factors for example, the salt-sensitive lifestyle or westernizing culture or something like that. And do you think the salt is most important, or genetic background or important, or do you think the most important factor? Please give you an idea.
Thank you very much. So I think the salt is very much important. So especially for salt, the intake is closely associated with the culture and the food. So and also the salt sensitivity is worst for the American Africans. The Asian are intermediate, but we have the increased salt intake, so excluding expansion of the circulating volume, which increase the blood pressure from the younger age to advance the structural change of the vessels to advance the structural hypertension. So I think the salt is the most important. Okay. The next question from the Dr. Benkela Subramanian from Singapore. Thank you very much for your nice lecture. Is there a situation where some countries have a higher mortality from stroke than heart disease? Is there an explanation for this? Thank you. Thank you. Okay. カリオ先生、Q&A
質問されたよね。あ、ちょっと。
Please see the Q&A.
Q&A, yes.
Dr. Ramani from Singapore asked the higher mortality from the stroke than heart disease. Is Asian characteristics or something like that?
So, okay, thank you very much for asking. So I think the traditional Japanese and also Eastern Asian have the lower lipid intake. So we are we take a lot of salt, the traditional levels. So it's increase the stroke compared to the coronary artery disease. Coronary artery disease, compared to the stroke, the blood pressure reduction, its benefit is a little bit smaller compared to the stroke. So Asian, the hypertension related to the impact is increased, especially in the countries with the traditional salt, high salt intake. But the other countries, or the Malaysia or different countries, I know you have a lot of the coconuts. So coconuts increase the cholesterol. So, or not only the stroke, but also coronary artery disease should be increased. So food will make such a country-based difference.
Okay. The next question. Okay, please.
Excuse me. Kazumi, you gave an excellent lecture. Can I ask you about the use of salt substitute in Japan. You have shown the data from the salt substitute study in China. Our Australian friends, they did excellent study in northern China using salt substitution. I wonder whether in Japan you use those potassium salts or not in at home or in old people's houses.
Thank you very much for asking. I have two evidence. We conducted the RCT of the doctor guided introduced the low salt, but the other group was special nutritionist the advice to reduce the salt at the hospital. So for the outpatient, the hypertensive patient, the market reduction was 2.3 gram per day. Salt reduction was achieved, and by the special nutritionist, and the home BP and ABPM was significantly reduced when we evaluated by the home and ABPM by the special nutritionist. So we have the evidence for reducing the salt, but simultaneously the special nutritionist advised to increase the potassium intake. So I know you have some comments. The salt reduction is important, but using the diuretics, releasing the potassium is another increased risk for hypertension management. Do you think how important the salt reduction and the increase the potassium, which more important?
I think that increasing potassium is important, but of course, in hypertensive patients can be a little bit problem in those with renal dysfunction. That's a little bit problem.
Okay, thank you very much. So the time is up. So now I may close this session. Thank you very much, Dr. Carrillo, for the wonderful lecture. Thank you. Thank you very much.
Thank you very much. All.
Okay. So let's move the short lecture session. Dr. Rakugi and Dr. Hoshide, please.
Hello. Can you hear? Oh, okay. Hello, everyone. My name is Hiromi Rakugi from Osaka University, and I will chair with Professor Hoshide this session, this short lecture sessions. Short lecture session title theme is hypertension and hypertension-related diseases in Asia. And we called 5 speakers, and the 2 speakers will be chaired by me, by myself, and other 3 speakers will be chaired by Professor Hoshide. First, I would like to call Professor Jikan Wang from China. Shortly, briefly, I would like to introduce himself. He is a professor of cardiovascular medicine, Shanghai, Zhejiang University School of Medicine in China. He is a director of the Shanghai Institute of Hypertension and director of the Department of Hypertension Beijing Hospital. At present, he is coordinates several multi-center randomized clinical trials and the population and patient cohort studies. He has published more than 500 full-length articles and has lectured extensively in international and China national conferences. He is a former executive council member of the ISH, International Society of Hypertension. He's also immediate past president of the Asian Pacific Society of Hypertension, immediate past president of the Pulse of Asia Society, currently deputy president of the Hope Asian Network, and current president of the Chinese Hypertension League. He serves on the editorial boards of several international and China national journals in the field of hypertension and cardiovascular medicine as editor-in-chief, associate editor, section editor, or a member. So title of his talk is Current Topics of Hypertension in Asian Countries and Regions. Professor Wang, please start. Professor Wang.
Oh, sorry.
Thank you.
Is it okay now? Thank you very much, Professor Lakugi and Professor Hoshide. I should also thank Professor Hoya and Professor Kazumi Hario for the very kind invitation for me to attend this very influential and important symposium. So I would give a short presentation on current topics of hypertension in Asian countries and the regions. I would focus on these 4 topics. I will start with home blood pressure monitoring because in Asia, probably we need to implement this very important technique and for blood pressure control in our continent. So as you may see from this slide, with the use of home blood pressure monitoring, you can do a lot. For instance, in the identification of white coat and masked hypertension. So this home blood pressure monitoring technique can give very similar information on these diagnostic functions as ambulatory blood pressure. It is actually complementary to ambulatory blood pressure monitoring in this diagnostic.
Could you show slide? Could you share a slide?
Sorry. Oh yeah. Something wrong. Wow. You know what happened? Just me. Is it good now?
Yes, perfect.
Okay. So then,
yes, okay.
Is it okay now?
Okay.
Okay. So with home blood pressure monitoring, we can measure both morning and evening blood pressures. So then we can find those people with, for instance, masked hypertension. We recently did a study in this special form of hypertension in relation to cigarette smoking. We found that cigarette smoking increased the risk of masked hypertension. So in those people who smoke cigarettes, we can identify a lot of people with masked hypertension if we do home blood pressure monitoring. With home blood pressure monitoring, we can also improve treatment compliance and then increase blood pressure control rate. As you may see here in this particular study, home blood pressure monitoring increased blood pressure control for systolic blood pressure by around 15%, and for diastolic blood pressure on a very similar scale. So you can really use home blood pressure monitoring to improve blood pressure control. So then in Asia, we had already 2 home blood pressure monitoring summits. So we had this first summit in Shanghai, then we published this document on the status of home blood pressure monitoring in Asia. So we hope we can really improve home blood pressure monitoring in Asia in the next few years, especially with the new technologies, these wearable devices, and probably even in the future, cuffless blood pressure monitors. So then the second topic is about the use of innovative antihypertensive drugs. Because Asia is developing very fast, the economy actually increases in many Asian countries. So we have to utilize this advantage to develop innovative drugs for blood pressure control. As you may see here in China, we recently had this drug approved for hypertension, sacubitril valsartan. So we can use this drug for those patients with resistant hypertension because it is very effective in lowering systolic and diastolic blood pressure and pulse pressure. And it is also very effective in lowering nighttime blood pressure. As you may see from this 24-hour blood pressure profile, you see a very similar blood pressure lowering effect over 24 hours, including nighttime sleeping time. Then you see we are doing a multi-center clinical trial on these endothelial techniques, aprocitentan, and this drug is also for resistant hypertension. Hopefully, we can have this drug in the next few years in clinical practice. And another new drug is a selective mineralocorticoid receptor antagonist, KBP 5074. The drug has been tested in a phase 2 trial. You see a very significant reduction in systolic blood pressure in those patients with reduced renal function and very resistant hypertension. And we recently also did a trial in patients with masked hypertension using a Chinese herb medicine. And this herb medicine also reduced daytime systolic and diastolic blood pressure in these patients. In some, you see around 40% of patients, they had a very marked reduction in systolic and diastolic blood pressure, which was defined as 10 over 5 millimeters of mercury reduction in the daytime ambulatory blood pressure. And the third topic, I want to show you something we did very recently. We did a atrial fibrillation sequence trial in elderly Chinese. You see, we want to test intensive ECG recording in those elderly people, quarterly ECG recording versus annual ECG recording substantially improve the detection of atrial fibrillation in these elderly people. So you see the difference was more than 70%. So you can really find more patients with atrial fibrillation, especially in those high-risk people, elderly and hypertensive patients. Then you can improve the use of anticoagulants, then prevent strokes in these very high-risk patients. So because atrial fibrillation in China, something like more than 400,000 strokes, largely because of atrial fibrillation. So finally, I would show you a little bit what we did in blood pressure measurement in public areas. That's also something we want to implement in China in the next 2 years. I think it can be used everywhere in Asia and probably also in many other countries. So if we establish such a system, people, especially younger people, working people, they can reach blood pressure measurement facilities, so they can measure blood pressure in a coffee break of 5 minutes time. So we can improve blood pressure or hypertension awareness in these hard-working people. And another initiative is the main measurement MANS project. Many Asian countries and regions participated in this project. You see, we did measurements since 2017. So in the past 5 years, we measured blood pressure in more than 1 million people. And with this initiative, I think we can improve blood pressure measurements in China. You see, in these measurement activities, we found that blood pressure control rate was around 25% in China. Actually, Asian investigators contributed a lot to this international project. Approximately half or more than half measurement actually from Asian countries and regions. So finally, I would close my presentation by showing this slide again, because Katsomi and I a few years ago wrote this review to show the current status of blood pressure control in Asia. You see, in some countries, for instance, Japan and Korea, they did very well. They have very high control rate of hypertension, but in many other countries and regions, we still have to work very hard to improve blood pressure control. In the meantime, I hope we can do also some epidemiological studies together and to look at the current status and the future together. Thank you very much. Thank you.
Thank you very much, Professor Wang. So this session is open for discussion. Is there any questions from the audiences? Firstly, I'd like to start one question from. So thank you very much for comprehensive and beautiful lectures to us. I know very much about the differences in the blood pressure control rate are different between the Asian countries and regions. What is the major reason so big differences among countries in Asia? Do you have any opinion or comments?
I think first of all,
like that?
Yeah, I think first of all, health insurance plays a very important role. So in those countries with very good health insurance, for instance, Japan, Korea, and you did very well. I think in other countries, health insurance is improving. It will, I think, help us to improve blood pressure control. And the other thing is blood pressure measurement for awareness. If you don't measure blood pressure, of course, you don't know your blood pressure. Then you would never really consider hypertension at all. So I think if we Asian countries and regions, we can improve home blood pressure monitoring, or we all have home blood pressure monitors at home, and we measure blood pressure regularly. I think we can substantially improve awareness of hypertension. And the other thing, of course, we need to treat properly. And in this regard, and then we should communicate like in this meeting. So we should discuss the strategies, guidelines, and we can, I think, also improve the control rate in those treated hypertensive patients. That's my personal view on these three important aspects. Thank you.
Thank you. We invited three commentators to these sessions. And firstly, I'd like to call Professor Schiffer for these sessions, for these lectures. Could you give us comments or question from Professor Schiffer?
Yeah, I thank you for the invitation to the meeting. These are all fascinating talks that we are hearing this morning. I'd just like to comment on a couple of things. just, clearly the blood pressure control remains poor in many Asian especially the low and middle income countries. And I'd just like to comment on the huge global disparities in blood pressure control. And although the trends data that have been published recently by the ANCD risk group, and here Dr. Wang also showed the blood pressure control rates, and we are seeing the marked disparity in many countries within Asia. So the low-income countries, especially in South Asia, even in Indonesia, within Southeast Asia, there are countries that are not doing as well, some countries as compared to the others. So I think while there is, we've heard remarkable progress and excellent talks on how do we, on ambulatory blood pressure monitoring and the newer treatments, and we need to move in that direction in terms of, the BP surge, and also how Asians are more predisposed compared to other populations, and that's true. A lot of data from Japan and other Asian countries. And let me just highlight the fact that we have observed similar data from Bangladesh, that people in Bangladesh somehow have a higher risk of stroke compared to, it seems like compared to even within other South Asian countries. So there are some differences even within Asian countries, and it may be related to the higher salt intake, but we need to examine that more closely. But at any point, at any rate, the countries like Nepal, countries like Indonesia are very poor blood pressure control. And these trends data over the last 30 years that NCD risk group just published in the Lancet from 1990 to 2019 have shown that the rates have improved in many high-income countries, but are flattened, or there's no improvement in the poorer regions. So I think that's where we need to put in more effort into what we can do and learn from the things that are just being presented. How can these technologies and how have all the initiatives that have led to improvement in the higher income countries now be implemented and in the lower and lower middle income countries, and how can we overcome these disparities? And many of them are because of the social, environmental, and other political determinants within the countries. So the health systems are weak, the population may be semi-literate, there are other things with the trade policies, that the diets are unhealthy. So we need to address them. The trial that just from China on the salt supplement is a very good example. How are those things are going to be scaled up? We have done some work on delivery with use of non-traditional models of community health workers, pairing up with the public health care infrastructure, and taking this care to the door of the patients, and giving lifestyle counseling, using behavior communication strategies. And again, similar messages on reducing salt intake. And in these countries, the dietary sodium is not used in the processed food yet in many of these countries, which is the case in Japan and in many other countries, but it's discretionary salt added while preparing food. So the approaches again are going to be different for reducing dietary sodium, but these are very salt sensitive populations. But just out of the box thinking and using approaches like that. And then what we've heard in the talks today is a lot of, again, digital technology will have great potential. We heard Dr. Wang talk about the web-based monitoring system. I think those are good for the urban areas and areas where there is a good digital infrastructure. We will have to use other different types of mechanisms for rural areas and the areas where the IT infrastructure is not as well developed. So we have to think of a lot of solutions, but clearly, blood pressure control will mean fewer CVDs, less direct, indirect medical expenditure, and then less productivity loss, better economies, and improved quality of life for many patients. So great talk, excellent what we are hearing, and can have great impact. We've got to think about low and middle income countries. Thank you.
Thank you very much. So time is up. So thank you very much. Professor Brown, do you have some comments?
No, thank you.
Okay, thank you very much, Dr. Wang, Professor Wang. I would like to move to the next speakers. Next speaker is, thank you very much, Professor Wang. Next, I will call Professor Park, Suha Park from Yonsei University. He is from South Korea, and he graduated from Yonsei University Medical College in 1995 and have been a faculty at the Yonsei University Cardiovascular Hospital since 2005. He is currently a professor in the Division of Cardiology with main clinical and research interest in hypertension. In the field of hypertension, his research interests focus on resistance hypertension, as that is today's talk, and biomarkers such as fundus photography for predicting cardiovascular outcomes, which were published in Lancet this year, and the blood pressure threshold for treatment and use of office blood pressure measurements in hypertension diagnosis and treatment. And today, Professor Park gave us a short lecture titled "A Single Center Study on the Prevalence and Prognosis of Refractory Hypertension Diagnosis using Ambulatory Blood Pressure Measurements." So, Professor Park, please start.
Well, thank you, Professor Rakugi, for the kind introduction. The current theme of this session is the current topics of HOMO and ABPM in Asian countries. Since the majority of major studies on out-of-office blood pressure have been done in Japan and some in China, and most of the data have been presented very elegantly by Dr. Carriol, I would like to share data regarding ambulatory blood pressure in our institution in Yonsei University. Since most ABPMs in Korea are not performed in primary clinics, rather it's performed in these general hospitals and tertiary hospitals. I think the data I present today will probably show some insight into the ABPM profiles in Korea. So briefly, the definition of resistant hypertension as it currently stands, the BP threshold for diagnosis and treatment should be in accord with current clinical practice guidelines. And the current recommendation states that it's either patients who have blood pressure above the treatment goal, despite taking 3 or more antihypertensive agents, or those with controlled office blood pressure with 4 or more antihypertensive agents. And there's a special subset called refractory hypertension, who have uncontrolled hypertension with 5 or more medications. Some include a definition, more strict definition that includes long-acting thiazide-like diuretics and spironolactone. And the current guideline states that patients with high code effect should not be included, and the diagnosis currently requires exclusion of non-urgent. So if you don't exclude high code and non-adherent patients, we usually define it as apparent treatment-resistant hypertension. So the epidemiology of resistant hypertension is kind of all over the place. Some data have it as about 20%. Some data have it at about 10%. And when I looked at the current literature, the prevalence of resistant hypertension in Asia is not very clearly defined. From Japan, I saw data that prevalence of resistant hypertension is about 4%. And actually, data that was published by Dr. Chia has the prevalence of resistant hypertension at about 8% in Malaysia. So the risk factor, it's more common in men, elderly, diabetes, and CKD. And as clearly shown by Dr. Carriel's data, there's a higher risk of cardiovascular events, and the reported hazard ratio is about 1.47. The patient characteristics is defined by older age, higher baseline blood pressure, obesity, and as discussed extensively, the excessive dietary salt ingestion. Chronic kidney disease, I believe, is one of the strongest risk factors. Diabetes, LV hypertrophy, and patients with previous stroke, which may have very significance in the Asian region. So currently in Korea, we have a government-sponsored multi-center cohort of resistant hypertension. It involves about 15 centers. It started about 3 years ago. And currently the participants is about more than 900 patients. This was an analysis that was done when there were 790 participants enrolled. You look at the age, the average age is about 60. There were more males. And since this, the inclusion criteria was office blood pressure of 130/80. So the average office blood pressure was about 139/80. And there was some discrepancy between home and ambulatory blood pressure, as you can see. The average home blood pressure level was relatively well controlled, but you can see that the average ABPM was elevated. But what was interesting was that in those with controlled office blood pressure, there was a very high prevalence of masked uncontrolled hypertension in these severe hypertensive patients. So about 59% patients who had office blood pressure below 130/80 had uncontrolled home BP or ABPM or both. And when you look at the data, those who had controlled home blood pressure, about 48.8% of the patients had elevated ambulatory blood pressure. And in those patients who had controlled ambulatory daytime blood pressure, about 18.6% had elevated home blood pressure. So when you look at these data, I think you need to perform both ABPM and home blood pressure to achieve optimal out-of-office blood pressure control. And also in patients with severe hypertension or resistant hypertensive patients, I think the diagnostic criteria or definition should be more focused on out-of-office blood pressure rather than office blood pressure. So in that regard, we analyzed the data from the Severance Hospital in Korea. So this was a ABPM registry retrospective cohort from 2012 to 2019. We looked at the cardiovascular mortality from the Statistics Korea, and we analyzed about 16,000 participants with hypertension who underwent ABPM. So we define resistant hypertension as those with uncontrolled daytime average BP, despite the use of 3 or more antihypertensive medications, including diuretics, or the use of more than 4 drugs, regardless of ABPM control status. Refractory hypertension was defined as uncontrolled daytime BP, despite the use of more than 5 antihypertensive medications. And so we excluded patients with hypertension, without hypertension. And so the final number was about 16,000. And from our data, about 8.9% of the total patients had resistant hypertension. And this was, I want to make sure that you understand that this is apparent treatment-resistant hypertension. We do not have any data regarding the adherence or secondary hypertension. So the apparent treatment-resistant hypertension was about 8.9%, and refractory hypertension was about 0.8%, which is in accord with the previous reports, which has been reported to be between 0.5 to 1%. And when you look at the clinical characteristics, there was a tendency for increasing BMI, obesity, diabetes, and myocardial infarction in patients with both resistant and refractory hypertension. And there was progressive increase in the prevalence of chronic kidney disease, ESRD, heart failure, and stroke. going from non-resistant to resistant to refractory hypertension. And you can see that in patients with refractory hypertension, 42% of the patients had previous stroke. And the profile of the medications, you can see that among resistant hypertension patients, about 14% were using mineralocorticoid receptor antagonists, which is 100% spironolactone almost in Korea, since we don't have a eplerenone. And for refractory hypertension, according to the guideline, I think about half the patients were receiving spironolactone for the treatment. And when you look at the lab data, as expected for refractory hypertensive patients, there was a very high prevalence of CKD. You can see that serum creatinine level was very elevated, and there was a decrease in eGFR. So there was a progressive decrease in renal function from non-resistant to resistant to refractory hypertension. And there was a very high prevalence of left ventricular hypertrophy in patients with both resistant hypertension and refractory hypertension. And when you look at the blood pressure data, it was interesting to find that there was a very high prevalence of risers and non-dippers in refractory hypertension. You can see that about 72% of the patients were either risers or non-dippers for refractory hypertension. About 58.5% were risers or non-dippers in resistant hypertension, whereas about 48% were risers or non-dippers in non-resistant hypertensive patients. So you can see that under 50% of the patients who did not have resistant hypertension were either risers or non-dippers, which increased to about 58%, as you can see, in resistant hypertension, and more than 70% in patients with refractory hypertension. And when we look at the cardiovascular mortality, there was a progressive increase in cardiovascular mortality going from non-resistant hypertension to resistant to refractory hypertension. And when we looked at the Cox regression hazard ratio, there was a 1.66 increased risk in cardiovascular mortality for resistant hypertension compared to the non-resistant hypertensive patients. And for refractory hypertension, the risk for cardiovascular mortality was about 4.8 times the risk compared to non-resistant hypertension. There was a similar trend for all-cause mortality as well. When we look at the interaction for various subgroups, there wasn't any significant interaction between age, diabetes, CKD. But what was interesting was there was an interaction between resistant hypertension and non-resistant hypertension according to the dipping categories. For example, for dippers and extreme dippers, there wasn't any significant interaction. There wasn't any significant difference between resistant hypertension and non-resistant hypertension. But for non-dippers and risers, the cardiovascular mortality risk was significantly higher in patients with resistant hypertension. Whereas for refractory hypertension patients, there wasn't any significant interaction according to the dipping status. So in conclusion, in a multi-center cohort in Korea, there seems to be a high prevalence of mass controlled hypertension among subjects with resistant hypertension who seem to have controlled office blood pressure with 4 or more medications. So I think the diagnostic criteria should be more focused on out-of-office blood pressure measurement. And as I've shown you, there is a discrepancy between home blood pressure and ABPM. And I think both should be performed in these high-risk patients. Also, in the single center registry, 8.9% had apparent treatment-resistant hypertension, and about 0.8% had apparent refractory hypertension. Also, the prevalence of CKD, ESRD, heart failure, previous stroke, LVH, and riser non-dipping patterns progressively increased from non-resistant hypertension status to patients with resistant to refractory hypertension. And also, refractory hypertension and resistant hypertension had hazard ratios of 4.76 and 1.66 respectively for CV mortality. Although there was no significant interaction for CV mortality according to age, gender, underlying DM, and CKD, For resistant hypertension, there seems to be an interaction for CV mortality according to the deeping pattern. Thank you for your attention.
Thank you very much, Professor Park. I'd like to invite a comment, one of the commentators, Professor Yuk-Chan Chai.
Thank you very much, Professor Rakui. Thank you, Sung-Ha, for the very nice sharing of that information about ambulatory blood pressure monitoring. I think in most countries in Asia, in particular the Southeast Asian countries, the low and low middle income countries, even my country, which is middle income, the access to ambulatory blood pressure monitoring is actually not available. Even in my hospital tertiary center, we have very limited access to it, partly because of the cost. So besides using ambulatory, I know you have you shared with us very, very nice data. What else can we use to try and identify these people with resistant hypertension? Because what you showed to us was there's a huge discrepancy between the home and the ambulatory blood pressure measurements, the daytime, of course. Also, what could explain that as well? And finally, of course, lots of study has emerged that ownership of a home blood pressure monitor does not always equal better control of blood pressure. Usually, it's only about 2 to 3 millimeters better, unless there is IT, technology support and so on and so forth. Just your comments on that.
Yeah, I think I think that's why, under the leadership of Dr. Cardiovascular and our colleagues from Japan and Dr. Wang, I think we're trying to expand the use of home blood pressure and getting more data in the Asia region with regards to home blood pressure, because I think since the access to ABPM is limited, also in Korea, actually, for the primary physicians, not readily available. So
yes.
In Korea, we're trying to increase awareness for increasing the use of home blood pressure. And regarding the discrepancy of home BPM and ABPM, I think there are some similarities, but there are some differences, because home blood pressure is a measurement of resting blood pressure. So, but ABPM is more susceptible for elevation in, for example, in workplaces, for example. So I think the measurement, there are some similarities, but there are some differences that that accounts for the discrepancy. So ideally, I think you need both, but there are some limitations for that. So yeah, I think that's something that we need to tackle as a society.
Yeah. And of course, the other thing is, other ways of treating resistant and refractory hypertension. And one of the things, of course, is renal nerve denervation. Do you think this will come on in a big way? Because, you have shown us the data where they are all much more at risk for getting CVD events. Any bigger role of RDN, renal nerve denervation?
I think so. I think the indication won't be wide, because actually, the blood pressure, when you look at all the data, the daytime average blood pressure reduction is only about 5 millimeters of mercury, about effect of one drug, I think. So I don't know if a lot of patients would want to undergo a procedure that results in just 5 millimeters of mercury reduction. And you have to take into account the cost benefit, because it's very expensive. But for patients with resistant hypertension, I think still it has maybe a role for treatment, because the reduction of 5 to 10 millimeters of mercury of daytime BP may be a strong impact in patients with resistant hypertension, I believe.
Perhaps the other panelists may want to say something as well.
So before saying I'm receiving from the panelists, I'd like to introduce one question from the audiences. Dr. Assis, he have a comment. It is interesting to look for subclinical fail and aldosteronism in those patients with resistant and refractory hypertension patients. In one study, as high as 20% with primary hyperaldosteronism was found in those with resistant and refractory hypertension. Has Professor Park has already search the prevalence of these clinical trials situations?
Yeah,
So,
I think that's a very important question. So the data have really shown that about 20% of resistant hypertension patients have primary aldosteronism. Personally, for me, when I look at these patients, 100% I screen for primary aldosteronism and pheochromocytoma, but in the real world hospital settings, majority of patients do not undergo screening for primary aldosteronism. If the patient were to receive treatment in, for example, endocrinology or for nephrology clinics, they may not undergo screening for primary aldosteronism. So we say a lot of the patients have missing data. So I think more education is needed to focus on screening for primary aldosteronism and, for example, sleep apnea. I think is another important secondary hypertension causes in patients in resistant refractory hypertension. Yes.
Thank you very much. So we don't have so much time, so we'd like to move to the next speakers. Professor Hoshide, please assist me.
Thank you very much. My name is Satoshi Hoshide from Jiji Medical School in Japan. So next speaker is Kei Asayama from Department of Hygiene of and Public Health, Tokyo University School of Medicine. Recently, I frequently contact with him because I and he was working as an editor of paper as our blood pressure monitoring. So thank you very much, Kei. Please start the presentation today.
Thank you very much, Professor Hoshide, as editor-in-chief in blood pressure monitoring. And thank you very much also, Professor Rakugi, for inviting me such a great session. Today, I would like to provide the current topics of blood pressure monitoring in Japan. Here is my share disclosure. So today, I would provide 3 topics, such as the first is the remaining issue on home blood pressure, especially the evening home blood pressure differences. And the automated unattended office BP, so-called AOBP, shall we use this more than home blood pressure, findings from the COSAC study. And the last one is the alternatives of the Mercury device for epidemiological longitudinal study. So first, as you all might know, the self-measured home blood pressure has a vast evidence for the management and treatment of hypertension. It has a better predictive power, more than conventional blood pressure, and comparably cheaper, and it is free from white-hot effect. The home blood pressure-based diagnosis of hypertension is prioritized. So it was established in 2014 Japanese Society of Hypertension Guidelines first and took over in the current guidelines in Japan. However, there are a lot of remaining issues on home blood pressure. In particular, there are the morning-evening difference in general population, especially in Japan. As you see, the home blood pressure-based management of hypertension is widely accepted in Japan. Also, ambulatory blood pressure is still the primary out-of-office blood pressure in other countries. Evidence on home blood pressure is increasing. However, the conditions on the evening measurement differ. As you see this slide, this is an ad hoc or the IPV-based meta-analysis of the 5 general population cohorts. There are varied measurement conditions among population, especially in this Ohasama for 4-week measurement. The evening blood pressure was measured just before going to bed. But in other European countries' data, evening blood pressure were captured during dinner time. Therefore, we conducted the so-called modern database of self-measured home blood pressure, and to demonstrate the current status of home blood pressure in Japan by integrating aggregate summary data from 5 general Japanese population cohorts started since this century. All devices are, as you see, by the same manufacturer with the same algorithm. and home blood pressures were in all cohorts measured every morning with 1 hour of waking before taking breakfast and antihypertensive agents after urination, and every evening just before going to bed. It complied to the recent Japanese guidelines. And this is the prevalence of morning home blood pressures. Please note that this is just the summary aggregate data. Therefore, the error bar in this circular triangles shows the 95 confidence interval of the average level, not the standard deviation, nor the variety of the individual data. Therefore, to see the average level, systolic blood pressure increased with age increment. However, the diastolic home blood pressure tended to decrease with age, except in women, untreated women, but slightly. So the peak of the diastolic blood pressure rise in an office setting were reported around 60 years of age, but was not clearly seen by home blood pressure. And there were no statistical differences, heterogeneities among 5 cohorts, surprisingly. For evening blood pressure, home blood pressure, this is the same trend as home blood pressure, morning home blood pressure. However, the difference between morning and evening home blood pressures in treated people, untreated people was more than 5 millimeter mercury in women and more than 7 millimeter mercury in men. And the difference in treated patients was more than 2 to 3 millimeter mercury larger. Morning home pulse rate, meanwhile, were within a narrow range, averaging mid to late 60 blood pressure beat per minute, irrespective of sex, age, or medication. And the evening pulse rate was faster than the morning pulse rate. So from the IDHOCO, all the IPT meta-analysis, the morning and evening difference is surely observed, but only from the OHASAMA, morning blood pressure is higher than the evening blood pressure. And it was more obviously observed by the current MDAS Japanese cohort. Therefore, I support the according to the findings. The separate home blood pressure thresholds for morning and evening might be needed. Of course, there is a need for some more evidence, but the prevalence must be different. So the next topic is, shall we use automated unattended office blood pressure, so-called AOBP, more than home blood pressure? AOBP is very stringent definitions, and there's a lot of advantage, but also has problems, such as AOBP information is said to be free from white coat effect. However, it is still affected by at clinical or at hospital effect. As you see, the right panel sheet, the AOBP is measured in the hospital. Therefore, there must be the clinic effect. However, self-measured home blood pressure is, of course, free from white coat effect of all kinds of observed effect or clinic effect. Therefore, I also emphasize that home blood pressure should be prioritized in diagnosis or sometimes in treatment of hypertension. However, the usefulness and the larger definition of AOBP is not clarified. Therefore, we conducted a study, comparison of self-measured home, automated unattended office, conventional attended office blood pressure. So from the COSAC study, this study, the relationship between AOBP and home BP is shown here in systolic measurement. The average level are almost similar for home, AOBP and home. However, it is impossible to see the very low correlation R values indicates that it is impossible, almost impossible to estimate the home blood pressure by AOBP level and vice versa. If one provides AOBP 140 millimeter mercury, but we cannot estimate the home BP value in this person. Whereas the relationship between AOBP office BP in systolic shows that there are good correlation between these two measurements. However, the level of AOBP was more than 10 millimeter mercury in systolic, lower than that of usual office blood pressure. Therefore, the AOBP, although the average home blood pressure and the AOBP levels are similar, the difference in the blood pressure of each patient varied remarkably. Therefore, AOBP can replace usual office BP value, but cannot replace home blood pressure. We should keep home blood pressure and ambulatory pressure as primary information of out-of-office blood pressure. However, of course, AOBP would be useful as in-office blood pressure information, alternative of in-office blood pressure, when we can cope with its high running cost in clinical practice. Anyway, accurate blood pressure measurement must be essential. And we recently provided the direct comparison of the mid to long-term reproducibility of these blood pressure information based on the COSAC study. It is accepted for the late-breaking session and will be presented today, this evening. Sorry, in Japanese. But not expected, but it was just published a few days ago. Therefore, I can provide the brief result as this: a higher reproducibility of home blood pressure was demonstrated compared with in-office blood pressure, compared with AOBP. Well, back to the office blood pressure measurement, there are vast variety of office blood pressure measure conditions as shown this slide. You see the rest periods differs. The most loose criteria is adapted for Japanese Society of Hypertension guidelines, but others 5 or more than 5 minutes of rest. And the measurement times differs, and the average of the readings also differs. So though the gold standards office blood pressure variations in measurement conditions still exist among the guidelines. However, in the first place, are they really compliant in clinical practice? I don't think so, and this is another issue, of course. Anyway, I would like to move on to the third topic of alternatives of Mercury devices for epidemiological and longitudinal study. So, Minamata Convention on Mercury came into effect in 2017. Therefore, in Japan, Mercury device can no longer be manufactured, imported, or exported since January this year, as well as many other countries. However, after phasing out of Mercury sphygmomanometer, what should be the alternatives of Mercury blood pressure measurement devices for epidemiological surveillance? Automated blood pressure monitors are unlikely to show the systematic drift over time for long years that leads to inaccurate of Mercury or analog devices. However, the initial drift from the beginning occurs on automated blood pressure monitors. As you see this table, slight but fundamental drift by automated devices compared with manual measurement by Mercury device were commonly observed in many epidemiological studies. Therefore, such systemic drift is inevitable by automated device, even though a semiconductor pressure sensor automated device embedded technology is almost free from aging deterioration. And for epidemiological longitudinal study and surveillance, to eliminate an error between an old and new device is essential for evaluating the reliable blood pressure level among population, or the comparison between the old and new blood pressure level. Such BP change shall be measured accurately. However, a systematic error between two different blood pressure measurements can be more than 4 mm Mercury, even when both automated devices had passed the clinical validation protocol. In the Japanese Society of Hypertension recommends for automated devices at medical facilities, because those with formally accredited one, because it is indeed the good device for blood pressure measurement. However, especially for epidemiological studies, electrically generated pressure column, so-called EPC devices, is recommended because it provides the smallest differences in readings compared with Mercury device, and can be used in approximately the same manner as Mercury devices. So in Japan, there has been the blood pressure measurement done in the National Health and Nutrition Survey of Japan. It was established in more than 70 years ago. And the survey monitors the diet, physical activity, lifestyles, and others, and from the randomly selected 300 areas in Japan. And it serves as a comprehensive database of risk factors for NCDs. A Mercury device with a standardized method has been used as a gold standard for blood pressure measurement in this survey until 2018. And from 2019, the EPC sphygmomanometer, a mercury-free device, but semiconductor pressure sensor use embedded, has been introduced with routine inspection and periodical inspection maintenance. It seems good, but unfortunately, blood pressure data in the EPC monitor year seems systematically drifted. In 2019, systolic blood pressure levels in women were 2.5 per 2.7 millimeters of mercury lower than those in the previous year. Eventually, previous hypertension also fell down from the past year. There are some hypotheses on this drift. One, using mercury assist button on the EPC device resulted to the fall. It was reported from George Stelgio and others. You see this device, there's a hold button. You can use this button to assist the measurement of values. It seems good. Yes, it is a very good, good function. But to push the button action, result to 1 second or more delay for the measurement, therefore resulted to the lower blood pressure recordings. And the replacement of the blood pressure measurements encouraged observers to practice the measurement procedure intensively before the most recent survey. Or in contrast, the previous mercury devices using mercury device were less accurate. For example, neglected maintenance. Therefore, we are the PDCA cycle in operation for the next surveillance. And this is the final slide of my presentation. That is the list of the blood pressure devices independently assessed for accuracy. Several blood pressure related organizations, including Japanese Society of Hypertension, have made repeated calls for action, including better identification of appropriately validated blood pressure measurement devices. And since 5 years ago, we provide the annually updated device listing for all domestic users. But this is now in Japanese only. Therefore, it should be internationalizations soon. Thank you very much for your attention. That's all.
Thank you very much, EK. Thank you very much for summarizing the review of blood pressure measurement. So, unfortunately, we are running out of time, so I would like to proceed the next presentation. Thank you very much, Kei.
Thank you.
Next speaker is Akio Ishida from Department of Cardiovascular Medicine, Nephrology and Neurology, Graduate School of Medicine, University of the Ryukyu. Dr. Ishida, please start the presentation.
Okay, can you see this? Can you hear me?
Yes.
Okay. So I will start. It is great honor to be able to speak to you today. We have no financial COI to disclose about the presentation. As you can see, we Asians have much higher salt intake in the world. Salt is very important for our health, especially for hypertension. In modern countries, systolic pressure increases with age, and elevated blood pressure causes cyclic stress on the arterial wall and damage extracellular matrix such as elastin, and arterial stiffness further increase. Systolic pressure and arterial stiffness are closely related and may behave reciprocally as cause or effect, and they are both independent risk factors for cardiovascular events. Today, I would like to talk about these three topics. First, I will show you about the age-related change in blood pressure and arterial stiffness and their association with salt intake in modern countries. Second, I will show you Our recent data about the age-related difference of blood pressure and arterial stiffness in native Papuan population who maintain lifelong very low salt and high potassium diet. Finally, I will discuss about the treatment for vascular aging. In most modern countries, systolic pressure increases with age. Arterial stiffness, usually assessed by pulse wave velocity, also increases with age in modern countries. Several prospective studies reveal that arterial stiffening precedes blood pressure increase, and a higher PWV predicts incident hypertension. So, age-related increase in arterial stiffness is considered as a cause of age-related increase in systolic pressure. The correlation between salt intake and systolic pressure has been confirmed in many studies. In the PURE study, urinary sodium excretion was linearly correlated with systolic pressure in the data of over 100,000 people in 17 countries. In the 1980s, InterSalt study found that 4 isolated populations had very low salt intake, less than 3 grams a day, and their systolic pressure and prevalence of hypertension was very low. And they are called as no salt culture. In these 4 remote populations, Yanomamo and Xingu in Brazil, Highlanders of Papua New Guinea and Kenya, age-related blood pressure change was absent, which is completely different from those in modern countries. In modern countries, several intervention studies have examined the effect of dietary salt reduction on arterial stiffness. A recent meta-analysis from 14 cohort studies showed that the intervention with low salt diet decreased aortic PWV. In the same cohort, systolic pressure also decreased by low salt diet. I would like to emphasize that the intervention period is very short, only between 1 and 6 weeks. Continuing a dietary intervention in a study cohort is quite difficult owing to the modern lifestyle. This study compared age-related difference of PWV and blood pressure in 2 local populations in China over 36 years ago. In urban communities, salt intake was very high, over 13 grams a day. In rural communities, salt intake was low, around 7 grams a day. The prevalence of hypertension was significantly higher in urban population, and age-related change of aortic PWV and systolic pressure were slower in rural communities than urban communities. These results suggest that the age-related increase in systolic pressure is able to decrease by reduction of salt intake, and lifelong very low salt and high potassium diet can completely inhibit age-related increase in systolic pressure. Low salt diet also decreases PWV, but there are no data on PWV in population with very low salt intake culture. Now I'm going to talk about our recent data of native Papuan population. In 2012, we examined the blood pressure in 2 regions in Papua, Indonesia. Inhabitants of Sorova village still maintain a traditional lifestyle, especially their diet. Age-related difference of systolic pressure was absent. People living in other regions are influenced by social globalization, and their systolic pressure increase with age. Soroba is a very small village located in the central highlands of Papua, Indonesia. This is their traditional house. Their staple food was sweet potato. We evaluated BAPWV and echocardiography in this way. We examined 126 inhabitants in 2014. Their mean BMI was 21. Hypertension was observed in 5% of the participants. No inhabitants take any regular medicine, and alcohol consumption was prohibited by the government. Sweet potato was their staple food and accounting for approximately 80% of their diet. We assessed sodium and potassium intake of the 8 inhabitants using 24-hour record method. Their salt intake was very low, only 2.0 grams a day, and potassium intake was very high, over 6 grams a day. Median urine sodium to potassium ratio was only 1.10. This is the result of urine sodium to potassium ratio in population of INTERSALT study. Compared to other regions of the INTERSALT, urine sodium to potassium ratio in Papua was very small, like the inhabitants of the very low salt intake culture. At that time, Japanese consume high salt, and their urine sodium to potassium ratio was over 4.0. This is the main result of the study in 2014. Age-related difference of systolic pressure was still absent in this population, but unexpectedly, BAPWV was significantly correlated with age. Here, you can see the relationship between systolic pressure and PWV according to 3 age groups. PWV was positively correlated with systolic pressure in all 3 age groups. What is interesting here is that even in the normal systolic pressure, PWV was correlated with systolic pressure, and compared to younger people, older people had higher PWV even if the systolic pressure was very low. This age-related but blood pressure independent change of PWV may be due to structural stiffness. The concept of early vascular aging, EVA, and supernormal vascular aging, supernova, has been proposed. When we superimpose the data of Japanese people on the data of Papuan population, it will look like this blue dot line. Papuan elderly might be supernova, but still BAPWV increase with age. Finally, I will discuss about the treatment for vascular aging. Lifelong very low salt diet might completely inhibit age-related increase in systolic pressure. Reduction of salt intake decrease arterial stiffness. However, even with very low salt diet, arterial stiffness increase with age. Heart rate might be associated with increase in PWV because of repeated pulsatile stress throughout life. Many of inhabitants were affected by smoking, and it might be associated with increase in PWV. We are very interested in renin-angiotensin-aldosterone system in this population. Very low salt diet activate the renin-angiotensin-aldosterone system, and this might be associated with blood pressure independent increase in arterial stiffness. This study showed that plasma renin activity and aldosterone concentration were high in inhabitants of Papua New Guinea in 1988. Baseline salt intake was only 1.8 grams a day. Sodium loading with 128 and 256 millimole a day for 10 days reduced renin activity, and aldosterone concentration. Despite decrease in vasopressor hormone, systolic and diastolic pressure significantly increased after 10 days. In animal model, deletion of smooth muscle cell specific mineralocorticoid receptor attenuate age-related increase in PWV. In wild type mouse, spironolactone, a MR blocker, attenuate age-related increase in PWV without affecting blood pressure. These results might suggest that age-related and blood pressure independent increase in arterial stiffness is mediated by activation of MR. In human, a meta-analysis of 11 randomized trials showed that MR blocker reduced PWV compared to control, and the effect of MR blocker is independent of blood pressure reduction. This is our hypothesis. Salt intake is important for age-related blood pressure increase. Blood pressure independent MR activation in smooth muscle cells might be associated with increase in arterial stiffness. In high salt diet population, activation of MR in kidney and smooth muscle cells via aldosterone independent pathway stimulate increase in systolic pressure and arterial stiffness. Not only blood pressure control by sodium reduction, but also inhibition of MR-dependent pathway might be important for control of vascular aging. I would like to take this opportunity to express my gratitude to my all collaborators. Thank you for your attention.
Thank you very much for presentation, Dr. Ishida. So I'd like to ask the commentary for to make comment. Dr. Iseki, do you have any comment for this paper?
Thank you very much, Dr. Ishida. Can you hear me?
Yes.
Yeah, I'm very interested in the popular data. Do you have any blood data such as serum sodium, potassium?
Unfortunately, we do not have any data of the blood test.
They live in the high area, 1,600 meters above sea level, right? So it's not so hot, I think.
Yeah. There is no season. The temperature is always same. There is no winter, no summer.
How much? Like Okinawa, 20 degrees Celsius?
The temperature is very, the lowest temperature is 10, and highest is 28.
Oh, that's interesting.
Thank you.
Thank you very much for comment for Dr. Iseki. So, okay, so thank you very much presentation of Dr. Ishida.
Thank you.
I'd like to proceed the next presentation. Our next presentation is from Angela Iman Wang from Hong Kong. Unfortunately, she cannot attend this meeting today. So in advance, we received the recording from her. Okay, please start the presentation office.
Good morning, ladies and gentlemen. First of all, I would like to thank the Japanese Society of Hypertension for inviting me to give this presentation. The title of my talk is Ambulatory Blood Pressure Monitoring in Peritoneal Dialysis Patients. And I'm Dr. Angela Yimun Wang from Hong Kong. The KDIGO Controversies Conference report has recently suggested the use of ambulatory blood pressure monitoring in dialysis patients. However, there are so far very scanty data in the PD population. There are data in the general population as well as in other kidney disease populations or in hemodialysis population to show misclassification of blood pressure control using office blood pressure. And ambulatory blood pressure may be more closely associated with hypertension-induced organ damage and in predicting cardiovascular event risk, and also identify masked hypertension and white coat hypertension. However, ambulatory blood pressure is not very popular among patients. It is also very time-consuming and requires additional resources. So the objective of this current study was to examine ambulatory blood pressure versus clinic blood pressure in predicting clinical outcomes in kidney failure population receiving peritoneal dialysis. So we adopt a prospective observational cohort study design, and we recruit kidney failure patients receiving peritoneal dialysis in Hong Kong. Subjects who have systemic inflammatory diseases like active lupus, if they have chronic liver disease, malignancy, chronic leg ulcer, or chronic infections, they were excluded from the study. And altogether, we have recruited 235 long-term peritoneal dialysis patients into our study. We performed ambulatory blood pressure monitoring in these subjects for 24 hours. When they bring back the ambulatory blood pressure device, we measure their clinic blood pressure twice after they've rested for 15 minutes, and then average to give the final blood pressure reading. We also collected fasting venous blood for measuring the common biochemical parameters. We also measure their indices of dialysis adequacy. In patients who have acute coronary syndrome or active infections, all the examinations will be deferred for at least 1 month after resolution of the acute events. Patients were followed prospectively for a period of 57 months with or without plus or minus 27 months. Patients who underwent kidney transplantation or transferred to long-term hemodialysis were censored at the time of transfer to alternative renal replacement therapy. Essentially, we examined 3 outcomes: all-cause mortality, major adverse cardiovascular events, which included also heart failure, peripheral vascular disease, strokes, acute coronary syndrome, and sudden cardiac deaths. We also examined the 3-point MACE, which include non-fatal MI, non-fatal stroke, as well as fatal cardiovascular events. And then we performed statistical analysis. So here are some of the results shown. If you look at the baseline characteristics, about half of men, and the mean age is about 59 years. The duration of dialysis is rather short, only about 3 months. Over half of the subjects were diabetic patients, and 23% have background atherosclerotic vascular disease, 18% have heart failure. Body mass index was about 24 kilogram per meter square. For Charlson comorbid score, the average score was around 5. And on average, subjects were on 2.4 antihypertensive drugs, and 68% were receiving calcium channel blockers, and beta blockers were received in about 56%, and the RAS blockers were received by close to 70% of the subjects, and over 70% of the subjects were receiving erythropoietin stimulating agents. If we look at the dialysis parameters, the total weekly KT/V was about 2.4, and also the total weekly creatinine clearance was very good, about 96. And most subjects have a normalized protein catabolic rate of about 1 gram per kilogram per meter square. Only 7% of the subjects were anuric, and with an average eGFR of around 4.2. And on the average, subjects would perform about 6.3 liters of PD exchanges a day. When we look at the biochemical parameters, generally, these subjects were rather stable. Hemoglobin was around 10 gram per deciliter. Intact PTH was very high, about 26 picomole per liter. Serum albumin was around 35 gram per liter. So here present the ambulatory blood pressure as well as the clinical blood pressure readings. If we look at the 24-hour ambulatory systolic blood pressure, it was around 140, and this is in contrast to 138 if we look at the clinical systolic blood pressure. On the other hand, if we look at the day-night blood pressure, the nighttime ambulatory systolic blood pressure was around 136, while the daytime was higher, about 141. And if we look at the clinical outcomes of these subjects who were followed for a mean of 57 months, there were 35% mortality. 83 subjects died during this follow-up period, and 6% has underwent kidney transplantation. And we look at the incidence of 3-point MACE. Around 76 patients had 3-point MACE, of which 23% were non-fatal myocardial infarction or ischemia, 5% were fatal cardiovascular events, and 4% were non-fatal strokes. Here we compare subjects who remained alive versus those who passed away during the follow-up period. And I highlighted the significant findings in red. And what you can see is there was significant difference in the lowest daytime systolic blood pressure as well as the average daytime systolic blood pressure between subjects who passed away versus those who died. These are talking about the baseline blood pressure. So generally, those who died have, on the average, nearly a 10 millimeters mercury higher average daytime systolic blood pressure from the ambulatory blood pressure monitoring. In terms of the nighttime, we also see a very significant difference between the nighttime systolic blood pressure in terms of the average, which is average 12 millimeters mercury higher for the average nighttime, and also around 13 millimeters mercury higher for the lowest nighttime systolic blood pressure, and 15 millimeters mercury higher for the highest nighttime systolic blood pressure between those who passed away subsequently versus those who remained alive. And if we look at the overall 24-hour ambulatory blood pressure, we also see similar difference. That is, the subjects who passed away generally has 10 millimeters mercury higher baseline 24-hour systolic blood pressure, and also about 9 millimeters mercury higher systolic blood pressure for the 24-hour systolic blood pressure, even for the lowest one. And this is significant, highly significant. However, there was no significant difference between the clinic systolic blood pressure between those who passed away subsequently versus those who remained alive. We also look at subjects who subsequently developed 3-point MACE versus those who were free from 3-point MACE in terms of their baseline ambulatory blood pressure and the clinic blood pressure. And again, we see similar difference. That is, generally, those who subsequently developed 3-point MACE had a higher average daytime systolic blood pressure and a nighttime systolic blood pressure, as well as a 24-hour ambulatory blood pressure for the systolic component. However, there were no significant difference in terms of the clinic systolic blood pressure. We also look at the Kaplan-Meier survival curves in relation to the overall survival probabilities. and we stratify the nocturnal blood pressure into different categories. And what you can appreciate perhaps is that subjects with a nocturnal systolic blood pressure below 140 millimeters mercury generally have a lower mortality as compared to those who have systolic blood pressure at the nighttime over 140 millimeters mercury. And we look at the cumulative major adverse cardiovascular event-free survival probabilities. We also see similar finding, that is, those with a nocturnal systolic blood pressure below 140 millimeters mercury generally have a better survival outcomes in relation to the major adverse cardiovascular event-free survival probabilities, compared to subjects who have a systolic blood pressure nighttime more than 140 millimeters mercury. We also look at 3-point MACE and again showed similar finding, that is, those with a nocturnal systolic blood pressure below 140 millimeters mercury tend to have a better survival outcome in terms of the 3-point MACE. We also perform multivariable Cox regression analysis. Again, you also show similar finding, that is, clinic systolic blood pressure did not predict overall mortality risk. However, the ambulatory blood pressure, in particular the 24-hour systolic blood pressure, is predictive of a greater risk of all-cause mortality, and that was adjusted for all the other confounding covariates as listed here. We also look at the major adverse cardiovascular events. Again, we see the predictive values of 24-hour systolic blood pressure, as well as daytime and the nighttime systolic blood pressure. And among the three systolic blood pressure, the daytime blood pressure appears to be the most significant. And clinical systolic blood pressure is not useful in predicting major adverse cardiovascular events. And this is again adjusted for all the other confounding covariates. And we also look at 3-point MACE, and again we also show similar finding, that is, the 24-hour systolic blood pressure and the daytime as well as the nighttime systolic blood pressure are all predictive of 3-point MACE after adjusted for these confounding covariates, whereas the clinic systolic blood pressure were not significant. We also look at the ROC curves analysis, and what we've shown here is that among the different ambulatory blood pressure parameters, clearly the 24-hour ambulatory blood pressure as well as the nighttime systolic blood pressure appears to have the highest predictive value, or the area under the curve, as compared to the other blood pressure parameters. And do take note of the clinical systolic blood pressure, which was insignificant in predicting all-cause death. We also looked at the prediction of acute myocardial infarction, and again we saw similar finding, that is, the ambulatory nighttime systolic blood pressure was having the highest predictive value among the different blood pressure readings. And if we look at the major adverse cardiovascular events, again, the ambulatory nocturnal systolic blood pressure has the highest area under the curve in predicting major adverse cardiovascular events, and clinic blood pressure is not useful. And finally, when we look at 3-point MACE, we also show similar finding, that is, the nighttime ambulatory systolic blood pressure has the highest AUC in predicting 3-point MACE as compared to the other ambulatory systolic blood pressure parameter. And again, clinic systolic blood pressure was not useful in predicting 3-point MACE. So therefore, I would like to conclude my talk by saying that ambulatory systolic blood pressure is superior to clinic blood pressure, systolic blood pressure in predicting overall mortality and cardiovascular event risk in PD patients. Among the different ambulatory blood pressure measurements, nocturnal systolic blood pressure appears to show the strongest predictive value with mortality and cardiovascular event risk in our PD patients. These observations have important implications in defining the blood pressure targets in clinical care of PD patients, as well as in conducting clinical trial design targeting at improving blood pressure control in PD patients. With this, I would like to thank the organizing committee for inviting me. Thank you.
Okay, thank you very much. I think her presentation provides important clinical implication because there is a lack of data of the patient with peritoneal dialysis about the association between office or out of office blood pressure and cardiovascular events. So the time is just up, and thank you very much for attending this session. Thank you very much for presentation, Jin-Young Wang and Sunha Park Asayama, Akio Ishida, and finally Angela Wang. And thank you cooperating and several commentators, Dr. Jeffrey Chair and Dr. Iseki. Thank you very much. So I'd like to close this session. And thank you very much for attending this session, everyone. And the Asian Joint session will continue this afternoon. So see you after just a breaking time, and see you the next session this afternoon. Thank you very much.
Very much, Mr. Yamaguchi. So, good afternoon, ladies and gentlemen. Welcome to the session of ISH 2022 and JSH 2021 and Hope Asia Network Joint Session, Part 2, Network Conference on Hypertension in Asia. So, this is Akira Nishiyama, who is the chair of the International Committee of the JSH. And it's my great pleasure to be your moderator today. Today, leaders from 14 Asian countries or regions will attend this meeting, including China, India, Indonesia, Korea, Malaysia, Mongolia, Pakistan, Philippines, Singapore, Sri Lanka, Taiwan, Thailand, Vietnam, and Japan. So I'm now in Okinawa and wearing Okinawa formal wear named Kariyushi for this session. So I'm very sorry that we are not able to invite all of you to Okinawa, but I'm very happy that we are connected together remotely like this. So let me share my slide. All right. Let me briefly explain the roadmap for the Asian hypertension consensus with all of you in Asian countries and regions. Almost 1 year ago, we had the first remote meeting with leaders from Asian countries and regions. And we have decided together that we have a series of discussions to announce an Asian consensus on hypertension, probably at the ISH 2022 in Kyoto. As one of the steps, we have been conducting a survey on hypertension since June this year, and some of the results will be discussed today. Especially, it is particularly important to have a common understanding of the various issues in these states, and Okinawa Declaration will be released today. We will continue our discussions, including today's presentation, so that we can present our Asian consensus at the ISH 2022 in Kyoto. So in order to move forward with such plan, we are holding this session today. So I would like to ask Professor Kazuomi Kario, who is the Vice President of the JSH, as a moderator of next topic about the results of questioning by each country or region. So Professor Kario, if you please. Professor Kario, microphone on, please.
Okay. Oh, okay. Could you hear?
Yes. Yes.
Okay, but size should be.
Oh yeah. Yeah, something wrong about the slide. Okay, now
okay.
Slide
okay.
Okay.
Thank you very much, everyone. So I'm very pleased to have my talk on the outcome of the Hope-Asia network activity up until now. So today's I appreciate today's friends almost enjoyed and also enrolled in this Hope-Asia network activities. So let me start the history of the Hope-Asia network formation by doing. That by doing is very much important keyword. So we initiated the 2014 for the friends, the association, and to consider the Asian characteristic for the management of hypertension. And the 2017, the World Hypertension League, we can enroll as a member by the Professor Lackland and the Michael Webers. And the 2019, the ISH also accepted this activity as affiliated societies. And then we can go to the society level, the activities to join like this meeting. So Hope-Asia Network, its mission is to improve the management of hypertension and the related organ protection for the zero cardiovascular event in Asia. First initiative is to know the evidence up until now, to write the review paper. The second, to achieve the consensus. It's very much important to write the consensus paper. And third, to do the clinical research on the current status. So these are the members. We can see the very good friend Chia and the TD1 and the Jigan1, and also the Akshad, the other members, Dr. Singh, also Sunha Park. So as a first activities, Chia is always the first first runner. So he evaluates surveyed the current status of home blood pressure monitoring in Asia. The statement was released from Hope-Asia Network to the Journal of Clinical Hypertension. So as shown here, this is a basic blood pressure treatment, the activity status. Awareness, treatment, and control status of hypertension in Asian countries and regions. So China, Japan, and Korea, as shown here, control is dark blue. So Taiwan, Singapore, and the Korea, all these are the very good countries, like the Westerners. Japan is in the intermediate, the Pakistan and the Malaysia and the China, and should increase the control status. So we have the different control status even within the same the Asians. And also we surveyed the prevalence of the antihypertensive drugs as a monotherapy. As shown here, China, India, almost the Asian country likes the calcium antagonist, as shown here. Second, ARB, and also beta blockade. And then we write the review papers on the current status of the different diversity results of the management and the hypertension control status in Asia. This was the first activity. And second, we did the survey study using the same device and the same blood pressure management protocol using the validated device with a data memory. So we conduct the survey on the current home blood pressure control status. This is the Asia BP at home study. This was the result, office BP and morning home BP control status. As shown here, using the conventional threshold, 140 office and the 135 for morning home blood pressure, as shown here. Almost half were well controlled for both the blood pressures. It was very good, unexpectedly very good. But this is an average. When we applied this, the survey into using the new AHA-based the threshold, 130 for both. The control status was 26. So we still improve the control status for the blood pressure for office and the home. And this is more important result as shown here. The controlled hypertension status is different among the countries. Best was the Philippines, and also markedly from the 70 or more well-controlled, the controlled hypertension to 20% the poorly controlled. And masked hypertension and controlled hypertension. So still again, even the average level was well controlled in the current status, using the same device and protocol, we again confirm the different diversity control status of the home blood pressure. And also here, these are the measures of blood pressure variability. Again, the exaggerated blood pressure variability proportion was markedly different among each countries. So we have the different control status and the different blood pressure variability in each countries. And here, we identify the different country difference in the heart rate using this survey. East, southern, southeast, the east, southwest, and the south. We classified these three areas. Japan, Korea, China, Taiwan is the East of Asia. South Asia is India and Pakistan. And the others is Southeast Asia. As shown here, all the blood pressure measurement, blood pressure all the measurement, office, morning and evening, as shown here. The South Asia exhibited the increased the heart rate compared to the here almost the 7 to 10. So I don't know why the India and Pakistan had such an increased the heart rate, but some the factors will affect to increase the heart rate. As you know, the heart rate increase is the important risk factor for heart failure and the coronary artery disease. And also here, compare the Thailand and the Japanese. As shown here, the degree of morning surge and the nocturnal dipping status was different each the countries. As shown here, Japanese are likely to exhibit increased degree of morning surge, but the Thailand, the non-dippers and the risers are more common compared to the Japanese. So we can identify, as the Jeffers this morning said, even within the same area, we have a different demographics of the blood pressure 24 profiles. So we should consider these the characteristic to achieve the cardiovascular event zero. So this is a consensus panel, the recommendation for morning blood pressure from the Hope-Asia networks. So morning hypertension is we stress the importance of morning hypertension to decrease less than 125 for the management of hypertension in Asia, especially in high-risk patients. So a lot of the topic and the consensus were released up until now. 2020, the 35, and the 2021, 38 papers were released from Hope-Asia. So thank you very much for the contribution on this activity. So Journal of Clinical Hypertension, Jigan Wang is the editor-in-chief. He provided also he had very good leadership on Hope-Asia network activity. And he gave us the chance to release these papers. Thank you very much for your attention. So from now, the Dr. Hoshide, he's a very good co-worker with me, conducted the survey on the current status of hypertension for the questionnaire survey with younger doctors. So, Professor Hoshide, could you start your survey result?
Thank you very much. Okay. Can you see?
Yes, yes.
Okay.
But it seems likely that it's a speaker mode. So can you change, or I think that the speaker mode should also be okay, but if you can change, please change it.
先生、全部ちょっと見えてるのがね、右も見えてる。次のスライドっていうのは。
ちょっと
難しいよな、それが。
Yeah, I think it should be okay. Yeah, please go ahead.
Okay. Okay. Today I'd like to give you internal report on the result of the questionnaire that I have asked you all to help us. This survey item consists of the question about 7 major topics: demographics, lifestyle, environmental condition, instead of morbidity and mortality of disease, hypertension information, prevalence of use of antihypertensive drug, and blood pressure and blood pressure monitoring telemedicine in clinical practice in the information. The table shows the correction status of the questionnaire result of the demographic data provided by each country. As you can see, it is quite difficult to correct even demographic data perfectly. So here are some of the results, part of the results. First, this is a prevalence of the obesity of each country. For example, in China, it is about 50%, whereas in Singapore, Sri Lanka, Vietnam, etc., the frequency of obesity is less than 10%. But on the other hand, we should notice there is something to be noted. The definition of obesity may be different according to the country. For example, in China, the obesity is defined by overweight obesity, and with 18 years old, in Korea, the obesity was defined by more than 25 in body mass index, and with 20 years. Next is prevalence of diabetes in each country, as well as prevalence of obesity mentioned earlier. The definition may be different according to the country. For example, in Japan, the diabetes was defined by HbA1c by more than 60.5 or under treatment. And in Korea, the diabetes was defined by fast glucose with more than 126 milligrams per deciliter. This is the prevalence of smoking. Most countries shows a percentage the smoking in total in the country that shows the frequency by gender. The percentage was very different between male and female. This is the amount of salt intake. It is about 8 to 10 grams per day in most countries. But there are several countries that do not have the data. It shows a prevalence of hypertension, treated hypertension, or controlled hypertension. The part of the result have already demonstrated it by Professor Cario. We acknowledge that there is a considerable variation amongst countries. On the other hand, as for the guideline of the management of hypertension, we found out that each country has its own guideline. This is a percentage of physicians who treated patients using home blood pressure monitoring. Many countries did not have enough of this information of the data. This result may also change depending on the physician who is targeted. For example, if we target this hypertension specialty for hypertension, probably the percentage will increase. So the summary of this presentation. This is a discussion of the result of this survey for the Asian consensus. I think it is very difficult to aggregate the survey from each country because definition classification is different. There's no information in many regions according to the contents. just looking at the results so far, it is clear that there's much diversity in Asia. On the other hand, each country has a domestic guideline for hypertension. For future direction of our Asia consensus, we need to focus on some specific topics. Thank you very much.
Okay. Thank you very much, Professor Hoshide. So, do you have any, the audience, do you have any comments or questions on this survey and our directions?
Professor Kario, I'm Akira Nishiyama. Probably today we have three relatively young scientists from Japan, so maybe they also involved in the questioning. So probably they have a specific comment. So yeah.
Good. It's good. Good. Great idea. So, Professor Katsurada, first, please.
Okay. I'm Kenichi Katsurada in Japan.
Could you show your picture? So it's important to show picture.
Video. Can you hear me?
Yes, I can hear you.
Okay. I have a comment for the survey. Thank you for your presentation, Dr. Hoshide. And you showed that each Asian country has its own guideline for hypertension. So I think it is very important to show the guideline each other and find out whether there are any differences among the Asian countries. So I'm interested in whether there's a difference in the diagnostic blood pressure for hypertension and the target blood pressure for treatment in each country. Thank you.
Thank you very much.
Prof. Kario, can I sort of answer the question a little bit?
Yes, please.
We at Hope Asia Network have actually published a paper on comparison of guidelines in the JCH this year. So it's all very well tabulated about thresholds of treatment, target, what drugs they want to use, all in there. You should be able to find it there because I did the paper, so I know the data. Yeah, Dr. Katsurada, you can reference that paper. You can see that paper.
Okay. Thank you for your comment. I will check the paper.
Yes.
And the Professor Yamamoto, please.
Thank you, Professor Kario. First of all, I would like to thank you, all the professors, for giving us answers to the questionnaires. So please let me give some comment on the results. And among the results, I especially focused on the salt intake in every country. So as shown in the previous slide, we can see generally high salt intake in each country. Maybe this is higher than countries expected in the European countries. So I think that salt reduction is a very essential strategy to treat hypertension, particularly in Asian countries. So I think that it is good to make some consensus on salt intake target in Asian countries. This can be a very good goal of this project. This is my opinion. Thank you.
So thank you very much. For today, the morning sessions, some doctors said we need the salt tax. So it may be too strict. As a population approach, could we have very good idea? Professor Apishad, do you have any idea to facilitate salt reduction as a population strategy?
I think it is quite difficult because the whole Thai government and the Ministry of Health have tried it for nearly 20 years. And it doesn't seem to move much because it probably is our tradition to encourage using salt in cooking. And also we are in a very hot country. So when people stay in hot country, they are craving for salt all the time. And I also have learned from the data that just published that the salt substitution can help. But accordingly, salt substitution may not work for the people who move into the city because it's suitable for those who cook their meals at home only. And for salt substitution, it should be used for all the members in the family, not just the patient. So it's still a long way to go in terms of salt control. Probably we should move on by using calcium channel blockers, also with the diuretics, as you mentioned earlier this morning.
Okay, thank you very much.
Mario, can I just talk from India?
Yes, from India, please.
Thank you very much for involving me for this particular symposium, and I'm really grateful to all of you who have joined this particular session. India actually has got its own studies. There is an India Heart Watch study, #1, with respect to the prevalence of hypertension in our country, #1. Recently, the India Heart study had been published, and this has actually categorically mentioned about the heart rate, which is actually more in the evenings, and it has been projected even in the slides what the other gentleman was showing. The heart rate in Indians is always higher in the evening time, #1. #2, the blood pressure is also surprisingly higher in the evening time. That is #2. #3, the salt intake in our country is exceeding nearly about 12 grams of sodium chloride. Sodium chloride, 12 grams or so. I think the salt consumption probably may be the main culprit for increasing the blood pressure, particularly in younger population. And of course, we have been repeatedly requesting all our doctors to educate the patients and the relatives to cut down the salt. And that reminds me that recently, about 2 days back, the FDA has given a guidance to almost all the restaurants in their country and the food manufacturers also to cut down the sodium. And it looks as though they are going to probably implement it, and they're expecting about 12% reduction in the sodium intake by those people who are visiting the restaurants or people who are actually involved in food manufacturing technology. And if this becomes a success, probably they'll be in a position to reduce the morbidity produced by hypertension. And the next point is that the home blood pressure monitoring, it is now being practiced by almost about 70% of the doctors, not only the general practitioners, the consultants also, they try to practice this way and advise the patient how best they can probably examine their own blood pressure at home, and they come back with the results at the end of 1 week or the end of 10 days to not only to diagnose hypertension, but also to prevent the complications of hypertension. I think it is time for us to educate our patients, the relatives, with respect to the home blood pressure monitoring, which plays a pivotal role for us to detect, for us to proceed further in updating the dosage of the drugs and prevent the complications in the long run. That's my view about it.
Thank you very much for your very valuable and the integrated comments. Thank you. So last, the Professor Yano, please.
Thank you so much for this opportunity. And my question, just minor comment is because the results from presented by Dr. Hoshide are mostly demographic variable. So in terms of that, how to, so the key is the standardized methodology and how to perform a sampling. So in terms of that, I'm very surprised because Dr. Carriol already conducted such a international survey using a standardized device, blood pressure measurement, something like that. So in the future, to increase the scientific robustness, I think we need a very similar approach as Dr. Carriol did in terms when we do international collaboration. So I think that's the key. So standardized methodology and how to sampling how to perform a sampling. That's the key to perform an international survey. Thank you.
Thank you very much. We need keeping the study to make the evidence. So thank you very much for your valuable comments. So let's move on to the next topic. Nishiyama, please.
Professor Carriol, thank you very much, and also presented and discussed. It is very, very important questionnaire survey. So maybe we can keep this activity in the future. So we can move on the next session, topics in hypertension in Asia. I would like to again Professor Kario and also Professor Hiromi Rakugi, who is the president of the JSH, as the moderators of these topics. So Professor Kario and Professor Rakugi, if you please.
Professor Rakugi, please. He's a president with a strong leadership.
Thank you very much, Professor Kario and Professor Gishiyama. We will chair this session, moderate this session about the topics in hypertension in Asia. First, we will have 3 speakers lectures from Professor Jikan Wang, Professor Tandao Wang, and Professor Yukchin Cha. First, I would like to call Professor Wang, Jikan Wang. He has already presented this morning, but again, we will call him. His presentation is, he is now the professor in the Shanghai Institute of Hypertension, Department of Hypertension, and Liujing Hospital, Shanghai Jiatong University School of Medicine. So his title is, topics is, what is important Asian characteristics for hypertension management? Professor Wang, please.
Thank you very much, Professor Rakugi again, and thank you, Professor Kario and many others for the very kind invitation. I believe the Hope Asia Network is working very well, and we will contribute to the management of hypertension in the future. So what I'm going to talk is about Asia characteristic for hypertension management. So my task is to discuss current status of cardiovascular disease and the impact of hypertension and Asian specific causes to increase blood pressure. Of course, this is a very comprehensive presentation. I would only touch some points of these questions. So a few years ago, I discussed in several meetings on characteristics of patients in Asia. So we discussed high sodium intake, high nighttime blood pressure, and high stroke incidence in Asian hypertensive patients. Here you see the comparison between 4 countries in urinary sodium and potassium excretion. So you see Chinese and Japanese had a higher urinary sodium potassium ratio than the British and American populations, both in men and women, and especially the Chinese had the highest ratio among these 4 countries. Then if we look at blood pressure, the nocturnal fall across so many populations from Asia, from Europe, you see the Chinese, Japanese all had a smaller nocturnal blood pressure fall than the other populations. So it means that we probably have a higher nocturnal blood pressure than people living in other continents. And of course, since many years, the Asians had the highest stroke incidence. So we probably have to do more in preventing stroke and other cardiovascular complications of hypertension. So if we then look at the current status of cardiovascular disease in Asia, there are actually 2 different situations. One is in more developed countries and regions, for instance, Japan, Korea, and Taiwan. and probably also Hong Kong, you have even slightly decreasing trend in the incidence of cardiovascular diseases. But here you see the data from China since many years. You see for hypertension, and there is a very substantial increase in those about 60 years from around 5% to 27% in the prevalence of hypertension. Very similar trends for diabetes mellitus from the 1980s, less than 1%, now over 10%. So it is a very big change in those around 40 years. Then if we look at the national statistics in cardiovascular diseases, then you see very similar trends as hypertension and diabetes mellitus, both in urban and in rural areas. Especially in rural areas, you see the increase was from around 170 per 100,000 people in the 1990s to the current more than 340 in those rural areas. So you see a very big increase and still increasing trend in the incidence of cardiovascular disease mortality. Then if we look at the stroke mortality, and you see a very similar trends, but you see already, of course, quite high 20 years ago. Now it was even higher. And for coronary heart disease, it was not that high in the beginning of this century, but now the incidence of coronary events and mortality increased about 3 to 4-fold, especially in rural areas. So we see a very sharp increase in China and probably also in other fast developing countries such as India and Southeastern Asian countries. So if we then look at the strategy, how we shall handle or deal with this increasing cardiovascular disease burden, there is a very recent publication from the Georgia Institute, but the data was collected from northern China. That's the SALT substitute trial. So they have shown a very significant reduction in the risk of cardiovascular events and mortality by the use of salt substitution. So it means you increase potassium intake and decrease sodium intake, then you can prevent stroke, coronary events, and all the other cardiovascular diseases. So you see, it is very important to do something in the lifestyle or in a healthy lifestyle. And here you see the data we recently collected from Shanghai. So we look at alcohol intake and atrial fibrillation. It has been shown a very close link between these two factors. But here, what I want to show is the very big risk in women who also drink alcohol. So it means that if women drink alcohol, then they have very high risk of atrial fibrillation in the Chinese elderly population. Here we have seen a very big odds ratio, so probably it is very important to reduce or even do not drink alcohol for women. So we have to look after lifestyle risk factors. So I classified those risk factors in 4 different categories. So the first, inhale. Actually, a lot of Chinese and other Asian people, and they still smoke cigarettes. And another major issue is particularly matters. It is increasing big problem in many Asian countries, and calorie intake, alcohol intake, salt intake, and many other nutrients intakes are also very important, and of course stress. Even sitting, if you are always sitting, it is a very important risk factor for cardiovascular diseases. You should better walk and run, then you can reduce the risk of diseases. Healthy lifestyle is particularly important, but it is not always easy to implement a lifestyle interventions. So that's why we probably still have to watch and treat hypertension and other cardiovascular risk factors. Here you see the data from many Asian countries. Katsuomi collected the data from many different studies from Asian countries and regions. You see we are to some extent different in controlling hypertension. I would propose that we do two very important things to improve hypertension control. First of all, we should try to measure blood pressure in all Asian people. So everybody should measure blood pressure, not every 5 years, not every 5 days, but you should measure every 5 weeks or 5 months. Then you know your blood pressure, regardless whether you treat or you don't treat, but you know your blood pressure. That's very important. You see the data from China, from the main measurement MANCH project. So if you measure, then you know blood pressure, you can increase the control rate of hypertension. The other thing for Asia, I personally believe that it is very important is to use more effective and efficient treatment for blood pressure control, such as this drug. This drug has been approved for hypertension treatment in China. I think it will probably change the situation in China, at least in the next few years. So in summary, I would say that cardiovascular disease risk is high in Asia and still on the rise. That's a major problem for many Asian countries. So we have to do a lot in improving our lifestyle and probably more importantly, improving blood pressure control by any means. Thank you. Thank you very much.
And thank you very much, Professor Wang. Beautiful lectures. Very comprehensive and beautiful. This paper is open for discussion. Is there any comments from the audiences or questions from audiences? If no, we have, okay. Professor Ito, please.
Hello, John.
Hi, hello.
Very extreme talk. Just I want to ask you your last slides for the sacubitril valsartan.
Yeah. So,
and
this drug,
now in Japan, it is now open to use that drugs for the treatment of hypertension. What's your opinion, and how about the situation in China?
The drug has been recently approved for hypertension. I think this drug is particularly effective in lowering blood pressure, especially at night. So probably this drug will change to some extent the hypertension control in Asia. I personally I'm confident in the use of these drugs in improving blood pressure control in Asian countries.
Okay, thank you.
Thank you. Is there any comments? If no, I would like to move on to the next topics. We have a time after the 3 speakers' presentation as a discussion time. So at that time, we can discuss much more. So the next speaker is Professor Zhang Wang from Taiwan. His topics is, he is now a professor at the Cardiovascular Center and Division of Hospital Medicine, Cardiology, Department of Internal Medicine, and National Taiwan University Hospital. And his topic is how could we use home blood pressure measurement and or ambulatory blood pressure measurement in the hypertension management strategy in Asia? How about the thresholds of hypertension for each blood pressure management? So, Professor Wang, please.
Yeah, thank you, Professor Raguji and Professor Cario for your very kind invitation. So can you hear me?
Yes.
Yes. Okay, good. Thank you. So all my good friends from the Hope Asia Network and also Japanese Hypertension Society, it's my great honor to join this symposium. And the topics, including the two tasks assigned to me, and I will, in the following 10 minutes, I will make a brief discussion. So the first question is about the role of home blood pressure monitoring and ambulatory blood pressure monitoring in hypertension management. And the second is about their thresholds. Traditionally, I think we all use home blood pressure. We all use or ask the patients to measure their blood pressure at home. And the traditional way is to handle the home blood pressure as a confirmatory tool. That means we rely on office blood pressure, but a standardized office blood pressure. And then if we found there's evidence of hypertension, the blood pressure is above 140/90, and we ask the patient to measure their blood pressure at home and to confirm the diagnosis and then the following the treatment strategy. But we all know that there is a white coat effect, and the office blood pressure is usually not that reliable. So in clinical practice, we usually use the home blood pressure. For me and myself, I heavily rely on home blood pressure and to adjust the medication and to provide some advices. So in this year, the Taiwan we want to renovate our hypertension guideline, and there are some important differences as compared to the previous version. The first is the definition of hypertension changed from 140/90 to 130/80 based on sprint and also the step trial. And we also move the home blood pressure. I mean, following the Japanese Society of Hypertension, we use home blood pressure as the main diagnostic criteria, the modality of blood pressure measurement, rather than office, because standardized office blood pressure is the routine or traditional way to diagnose hypertension, but the standardized office blood pressure is hard to obtain in our daily clinical practice. So home blood pressure, we usually put it as a confirmatory tool or during the management. But in this version of the guideline, we make a step forward to use home blood pressure as the sole diagnostic blood pressure measuring modality. So that's one difference. And before this version of guideline, we published the consensus in our Taiwan Hypertension Society about home blood pressure monitoring. So I think to integrate home blood pressure monitoring into the whole spectrum management, you should consider its role in diagnosis and in the management and in the follow-up. And among these three aspects, the first of all, you have to educate the patient how to measure home blood pressure and how to estimate the average home blood pressure. So we summarize all the studies and also the worldwide consensus. We created, actually that's created 10 years ago, the so-called 722 principle. So that included three important elements of home blood pressure monitoring. The 7 means 7 days because in the IDOGO study demonstrated 7-day average will be more representative and can be more predictive for future events. So the 7 means 7 days. It's a cycle, a 7-day cycle. So measure 7 days. And the 2 means 2 occasions a day after waking up and before sleep within 1 hour and before taking medication and after going to the toilets. And in each occasion, we educate the patient to measure twice and with 1 minute apart. So we averaged 2 measurements as a morning blood pressure and an evening blood pressure, and we averaged a 7-day morning blood pressure and also the 7-day evening blood pressure. But based on the global consensus, usually we discard the first day measurement and we measure the second day to 7 day measurement. So we have the so-called 722 principle, 722 cycle, and we have an average morning and evening blood pressure. That's we propose to educate our people to follow this. And then the question is about how frequent should we measure home blood pressure. So for patient diagnosed as or have a high possibility to get hypertension, we suggest everyone should undergo such a 722 cycle, at least one cycle, to confirm the diagnosis. And once the diagnosis has been confirmed and the medication being prescribed, 2 weeks later, we recommend then to measure the repeat the 722 cycle to evaluate the efficacy. And if the blood pressure not under control, probably every 1 month, we should repeat a 722 cycle. If the blood pressure is under control, every 3 months, you should repeat the 722 cycle. That's what we recommended in our consensus, also in our guideline. And in the management, we also recommend how to incorporate home blood pressure into our management of patient. So for every treated patient, the home blood pressure morning and evening 722 cycle should be repeated at least every 3 months. And so we look at if the blood pressure is under control in the lower part panel, it's all below 130/80. And we should look at the hypertension-mediated organ damage, like the ECG or the proteinuria. If there's evidence showing progression, and probably we should arrange ambulatory blood pressure monitoring to determine whether it is nighttime or some other kinds of hypertension that been not controlled. And if the morning is not, and also if the morning or evening is not controlled, we recommend 3 different medication adjustment strategies. The first is a bedtime dosing for those with nighttime or asleep hypertension, or you can change it to the longer acting drugs if the 24-hour blood pressure control is not achieved, or you can escalate the classes or doses of the medication. So these 3 management strategies should be applied according to different home blood pressure and ambulatory blood pressure profile. And we consider every patient we could monitor their ambulatory blood pressure, but at least if we should follow this left-hand side, the home blood pressure monitoring first, and then to look at the hypertension-mediated organ damage together. If both are under control, that's good. If there is either one of them not under control, we may arrange ambulatory blood pressure monitoring, and then to decide whether the timing or the doses of the medication is good or not. So that's what we propose for the management strategy for the home blood pressure monitoring and the ambulatory blood pressure monitoring in our daily hypertension management strategy. And then it's about the thresholds. In this version of the hypertension guideline, we move the diagnosis and the treatment target to 130/80 in Taiwan and using the home blood pressure. But that's somewhat different from Japanese hypertension guideline. And the rationale for Japanese hypertension guideline, I think mainly probably from the IDOCO study. So that's an international study from the data from China, Japan contributed quite significantly. And they, based on the outcome driven, the corresponding level to compare office and home blood pressure, and it seems that, so the home blood pressure maybe is a 5 millimeter mercury difference than office blood pressure, even down to 120/80. But in the American Hypertension Society, American Heart Association, and American College of Cardiology in the 2017, their guidelines, they provided such a table that been used quite prevalently. They show when the office blood pressure is as a standardized office blood pressure is reached to the 130/80 or lower, the home blood pressure is the same, are the same as the office blood pressure. So that may not create some confusion, because if we have a different number for home blood pressure and for office, that may cause some confusion. But what important is the true relation the true relation. So confusion is one thing. The reality is more important, I think. So the question is that a 5 millimeter mercury difference in systolic diastolic all the way down to 120/80 always the same in different studies? But actually, in the recently published study using the data from the United States, the Dallas Heart Study and the North Carolina Mass Hypertension Study, we basically, the rationale to get the corresponding level from office to home, there are two different approaches. The one is the regression. So you made a regression formula and to calculate. And the other, I think that being used in IDOCO and more evidence-based is the outcome-based approach. But I think the best is to base on randomized clinical trial, if that the trial is designed to use home blood pressure as the target, but there's no such trial right now. So we usually use the regression and outcome. But if you can see in this figure from the American population, you can see for the white, the empty, the white column, that's for stage 1, that means 130/80. The black column, that means stage 2, that means 140/90. So in the left-hand side, you can see based on regression approach, 130/80 is also similar to 130/80. And also on your right-hand side, so 130/80 is not equal to 125/75. It's equal to 130/80. But for the 140/90, it seems equal to 140 as well, and 90 in some ethnicity. So I think there's still some discrepancy in different studies about the corresponding level. And also in the recently published STEP trial done in China and also Taiwan, we joined, and we noticed we compare the office blood pressure and also the home blood pressure, as you can see, because in that study, the home blood pressure being asked to monitor at least once per week. So through the 3.4 years follow-up, you can compare the office and the home blood pressure side by side. And you can see here, for the 139 in the standard treatment group, the home blood pressure is actually even higher than the office blood pressure. So it's not always lower. In some cases, it's higher. So, or similar. So for the simplicity, we consider, and you can compare the diastolic blood pressure as well. So for simplicity, the upcoming our Taiwan hypertension guideline, we want to construct a whole spectrum home blood pressure based recommendation, not only for diagnosis but also for treatment targets, and we consider probably universally 130/80 for the treatment targets, and of course for some higher risk patients, stage 3 patient, probably if that's tolerable, and we can reduce the blood pressure down to 120/80 for high risk patient. But that's all for home blood pressure. So that's my last slide. I think for this threshold, well, and in different studies they have different corresponding value, and it's not really outcome driven, but some are regression driven. But for simplicity, we still consider probably we can make it the same as the traditional standardized 130/80, the same number 130/80. Thank you so much.
Thank you so much, Professor Wang. So is there any question or comments about his presentation? He presented about the thresholds of home blood pressure for hypertension, mainly.
Can I make a comment?
Yes. Who are you?
Thank you very much.
Oh,
I am
yes.
Richard from Thailand. I think that you did a very great job in trying to talking about the target blood pressure that we like to control in home blood pressure, because actually Professor Cario present the data from Hope Asia consensus that we like the blood pressure to be below 135/85. But at this time, I think that we are moving the clinic blood pressure downward to somewhere below 130/80. So in that case, if we still use 135/85 for home blood pressure target, it would not be appropriate. And I totally agree with you with the different level of blood pressure. There is some gap in the difference in terms of the clinic and home. So in that case, I think that your point well accepted, that we should try to make this less confused in our guideline. Because usually people believe that the home blood pressure always be lower than office. So I thank you very much for your idea about this. Very great one.
Thank you. Yeah, because I always wonder, I was curious about whether is that, well, always the home blood pressure is always lower than the clinic, the home blood pressure always lower than clinic or office blood pressure. In some patients, actually, well, there's a quite wide variation. Well, in general, yeah, right, agree. Because of Wyckoff effect, the office blood pressure is a bit higher, but that's non-standardized office blood pressure. If you in the clinical trial, you really look at that number, well, I think it's quite similar, especially because recently more studies demonstrated more aggressive blood pressure control is important, and in the lower range, I mean below 130/80. The difference is negligible, probably, and also probably well, almost the same. So for simplicity, because it always causes confusion, for maybe even for physicians, which target should be used. If we consider home blood pressure, maybe we should -5, but it's quite confusing. And for patients, they are not acceptable. So they always remember only one number, probably, so 130/80 or 140/90. So that's the reason why. But I do agree. I think probably we can consider to initiate some home blood pressure based studies in Asia, probably by Professor Rakugi, Professor Cardial. We can our Asian study to look at this issue, because maybe in different population there are different relations. But that's very important because we all believe in home. But it's seldom been discussed in the guideline. But so there's always some discrepancy. So, and I quite admire in the Japanese hypertension guideline, you are the first to introduce the home blood pressure as that's throughout the course of the hypertension management. So I think, yeah, the Asians should be the first to explore this issue in deep and provide evidence to the worldwide hypertension society.
I completely agree to Professor Wang. Professor Cardial, do you have any comments about his opinion?
So simplicity is very much important. And also, as you said, when the blood pressure level is higher, the discrepancy between the office and the home is greater. For example, 160 office is corresponding to the 145 for home BP. And then gradually decreased the 140 corresponding to 135. And as you said, the 130 or less, almost the same levels.
Yes. Almost same or different, some a little bit.
But for home BP is not for the hypertensive patient, but also high normal or the blood pressure, high elevated blood pressure patient. So the lower keeping the blood pressure is very much important. So that's why we decrease the blood pressure target for 125, corresponding to 130 for office BPs. So, but we need the evidence, and also I want to ask the Professor Wang to how many doctors use the home BP? Are you changing the diagnosis of the hypertension only based on the home BP?
Yeah, well, that's a very important question. Actually, we've been challenged by our colleague that they said that recommend home blood pressure, but not every patient they know they have a blood pressure device. So I would like to say, well, it depends on the which center you practice, but in general, probably 70 to 80% of people, hypertensive people, they have their own device. I would like to say the number in Taiwan because Taiwan is smaller, but the prevalence among hypertensive population for the device, they own their device, the number is about 80%. So that's quite high. And we recommend them to buy one because it's a chronic disease. It's a lifelong situation. So they have to realize themselves. So that will improve the adherence. And also I always said to them, well, you may not need to take medication all the way, all your life, but you have to measure because the goal of management is to keep the blood pressure within targets rather than taking medication only. The medication is a strategy. It's just a way to lower blood pressure. So in any means, if you can reduce your blood pressure continuously, that's fine. So under that education, I think that the adherence rate for regular blood pressure monitoring, and they provide their records to me, the number is very high. So I think we need education. I admit this kind of home blood pressure, the whole spectrum home blood pressure recommendation is still a little premature, but we have to educate our patient and also our physicians to accept this. But I want to mention one thing is usually with regard to the threshold, it's based on morning home blood pressure. But like the professor from India, he said in some places the evening home blood pressure are usually higher. So I think whether there is a similar relation, I think it's a very interesting topic to study. We routinely use the same threshold for morning and evening, and we may consider morning is more prognostically important, but I do think we should consider evening as well, and we do need more evidence on this on the evening home blood pressure as well, right? And maybe also the heart rate.
No, I see.
Can you permit me to give some comment from India?
Yes.
From India.
India, yes, please.
Yeah. Thank you very much, Dr. Wang from Taiwan, and it was an excellent projection that you made with respect to the home blood pressure monitoring. And I liked the 72 principle of detecting people with a home blood pressure monitor. Whatever is the threshold beyond which you make a diagnosis of hypertension, why always, most of the guidelines, you take European guidelines, you take American guidelines, you take Hypertension Society of India guidelines, or Taiwan guidelines, or Japanese guidelines, all of them try to come together as far as the goal is concerned. 130/80 is the goal for most of the patients, except for those very, very high risk individuals or people with the CKD or people with the diabetes, with a polyvascular disease in whom you like to bring down the blood pressure to the lowest level possible between 120 to 130. We have a good amount of evidence after the publication of a accomplished study, which started showing if you reduce the blood pressure from 140 to 130, you don't get much benefit. When you bring it down to below 130 to 120, always the better outcome as far as the morbidity and mortality is concerned. If you bring it down less than 120, the mortality goes up. So better not to bring it down less than 120. We should try to keep the levels less than 130 and above 120 in most of the individuals. I really appreciate the way in which you projected the data from Taiwan, and we need to remember that whatever is the threshold beyond which you make a diagnosis of hypertension, all of us has to remember that we need to focus our attention for the goal, and that should be only 130/80 as per the most of the guidelines projections. And that's number one. Number two, I would like to ask you one important question. Where will you place the ambulatory blood pressure monitoring to make a diagnosis of hypertension or to in the process of treating hypertension, where exactly will you probably advise the patient to go for ambulatory blood pressure monitoring? My practice as an individual, as a national president of Indian Society of Hypertension, I tell my patient at least once in your lifetime, you need to undergo the ambulatory blood pressure monitoring. Most of them, when they have the blood pressure increase, I try to advise this followed by the home blood pressure monitoring. Of course, home blood pressure monitoring is inexpensive, number one. I tell my patient, when you buy a glucometer to see what is happening to the blood sugar with the instrument in the morning and evening, why not to buy a simple apparatus which will give you an idea about the home blood pressure control, not only to update your dosage of the drugs or go back to the doctor to probably reduce the dosage of the drugs. Such things can be easily done. I talk to my patient. I think we need to emphasize the important aspect of our approach to the patient. We need to spend more time with the patient with respect to the information that we want them to adhere to, particularly for the management of hypertension, how important it is to emphasize the role of home blood pressure monitoring. That's my views. Thank you.
And that's very, okay.
We stop the discussion as the time is very short. So, so last question from Professor Yuda.
Thank you. Thank you.
He's waiting.
Thank you, Prof. Karyo and Prof. Rakugi. Prof. Wang, very excellent presentation and very wonderful 722. Just only the simple question that in your slide, the ABPM rule, that only if there is the target organ damage. Is it right in your guidelines?
Oh yeah, right.
Just only asking about it, whether is there any rule of at ABPM, not because of the patient already have the target organ damage. Thank you, Prof. Wang.
Right, thank you so much, Yuda, and also the Professor Nursing. I think the first question is about whether there should be recommended in the European guideline about the range of the targets, probably, and the 120/70 should that be the range? I think all the so-called J curve is and the lower point, the turning point of the J curve, will be defined as a lower range, target range, is based on post hoc analysis, and all the prospective studies demonstrated no. Definitely there will be a J point, but the question is the turning point when the risk will above the benefits. The point I think is far below 120/70 or so, and then that's individualized. So in clinical practice, it's very easy. We just ask the patient to observe if there is any symptoms related to hypertension, hypotension. If there's no, in higher risk patient, you can confidently reduce their blood pressure. So I think the first thing is that's individualized, and the so-called increased risk in patient treated blood pressure below 120/70, like in the on-target transcend, that's all post hoc analysis. So that have never been demonstrated in a prospective manner. And especially in the recently published STEP, that's been done in China and Taiwan, and the patient is very low risk. But even in that low risk patient, they can demonstrate the benefits, 26% relative risk reduction with a 9 mm mercury in systolic. So I think the blood pressure, the only drawback is not the blood pressure is not below 120. So we still recommend 130/80. But I personally think that will cause trouble if we consider the target. The target is within a range between 140 and 120 and 80/70. That's very difficult to apply. And that's maybe wrong, because for high risk patient, I truly believe lower on to 120/70 or 80 will be beneficial for them. And about ambulatory blood pressure monitoring, I did not take take too much time to discuss it, but I do agree both are about complementary, home blood pressure and ambulatory blood pressure. The drawback of ambulatory blood pressure is only 1 day or maybe 2 days, but that cannot be repeated very easily. So that can provide a very good information about nighttime and when the blood pressure will be up, and especially useful for patient, very emotional patient, very nervous patient. We can realize the true blood pressure status of that patient. So in our guideline, we did not devalue the ambulatory blood pressure. We actually put both together. But for the utility, I mean, because it's a chronic disease, I have to mention. So I do think the ambulatory blood pressure may not be once for a lifetime, maybe once a year or something like that. But it's not that easy like home blood pressure. So that's my answer for the second question. And finally, I think for any patient, if the home blood pressure is within targets, but the target organ damage is still continuous or even progressed, probably we should consider ambulatory. And the home blood pressure, if that's really good, we maybe should consider the ambulatory blood pressure, because sometimes you can observe patient with a higher blood pressure in the evening or maybe in the early morning, and you can make your fine adjustment of your medication. So that's it. But of course I agree. In any cases, you can recommend the ambulatory blood pressure. For me, I think it's more often used in the diagnosis, because quite a few nervous people, they got a quite extremely high blood pressure at office and maybe at home sometimes. But when I arrange an ambulatory blood pressure, you can see the average blood pressure is just maybe stage 1 or grade 1 hypertension. So that's my comment. Thank you so much.
Okay. Thank you very much. I would like to move on to the last speakers. Professor Carrier, please.
Yes. So Professor Chia, please.
Yes, thank you.
So she's a very active leader in Asia. So
I need to share my screen. Yes, I'm going to share my screen. Okay. Thank you very much to Professor Cario and the Japanese Society of Hypertension for asking me to share some of my thoughts on how to stratify and identify high-risk patients. I think the first question we need to ask ourselves is, why do we actually need to identify those who are at high risk? I think basically what we are trying to do is to identify those who will benefit the most, because there is good evidence that treatment of risk, whether it's primary or secondary, is beneficial. And particularly because of limited resources, and that is the case in many Southeast Asia countries where we are low or low middle income, we are trying to save the greatest number of lives at the lowest cost rate possible. But at the same time, we also need to balance the risk and benefit ratio in the sense that we do not want to induce adverse events of drugs on patients who are truly not at high risk and getting the medication. How to identify these individuals? I think it's very clear that anyone who has got an atherosclerotic event like a stroke, coronary heart disease, certainly they will belong to the very high risk group. But what about those who do not have cardiovascular events yet, but may be at high risk? And this is the primary prevention strategy on how we can identify such individuals. As I said, it's easy to recognize those who have already had an event, but what about those who do not have any events? How do we go about trying to decide whether they are really high risk? I think firstly, we need to remember that total cardiovascular risk is determined by the combined effect of cardiovascular risk factors, which of course coexist commonly and act multiplicatively. Here's just a demonstration of a survey that I did in a semi-rural community, age 55 years, mean age of 55. Clearly, we can see 3/4 of the individuals already have 2 or 3 risk factors. So they exist quite commonly. And then the fact that with each risk factor, there is a doubling of cardiovascular risk of mortality. So it's not a simple 1 + 1, but a doubling. And in the presence of diabetes, it is even further magnified. So just as a quick illustration, if we just look at a man who's very healthy, whose blood pressure is systolic is 120, who has good ratio of the lipids, does not smoke, the minute his blood pressure goes up to 160, and also if he starts to smoke and his cholesterol levels go haywire, his risk is increased substantially compared to an individual who has got good risk factor profile. We all know that age is an independent risk for cardiovascular disease, but we also know that the impact of blood pressure is greater in the older individuals compared to young adults. This is a study that looked at almost 1 million people, and clearly, again, it can be seen, this is the younger age group, these are the older age group, that the impact of blood pressure is greater in the older than in the younger age group. And if we were to take, say, 160 systolic, we can see that the impact on mortality, stroke mortality, is much lower in this younger age group than in the older age group. Now, besides age and blood pressure, we also know diabetes, dyslipidemia, and as well as smoking. They are all independently associated with cardiovascular disease. So how can we piece all these together? This is why the risk assessment charts were developed, starting off with the Framingham Heart Study. And of course, over many years, many other charts were developed. In Asia, we have certain communities, certain studies have created a chart that could be used. But I think how we need to use the tools is obviously, if you have your own country's tools, then it would be a good choice. But if you do not have your own tools, like many countries in Asia do not have it, is to try and validate existing tools in your own country. If you do not have any of that, then we should try and choose a tool whose background risk that we use is similar to your country. So just as an illustration, in Malaysia, when I looked at the background risk of our Malaysian population, and I look at the Framingham background, it is fairly similar. And that's why when we validated the Framingham Heart Study for youth, it worked quite well because the background risk is the same. And Malaysia's background risk is actually considered high. The other reason why we need to do a formal risk assessment is that if we just look at this man who's 65 years old, blood pressure doesn't seem to be very high, clean person, clean living person, no diabetes, doesn't smoke, lipids a little bit out of the optimal range. If we just look at him just at surface value, one might dismiss him as not being at very high risk. But when we actually put the risk score prediction on him, regardless of which tool you use, it is all says he's high risk. And that's why it is important to actually do a formal risk assessment. Based on the risk assessment, of course, we know that if the person is high risk, we treat. If it's low risk, no treatment. But what about those who are at medium risk? The recommendation there is quite silent. It's not as clear cut. And again, before we decide what to do, we need to think in terms of when we are treating the high risk, we are treating this small group, but yet there's all these numbers of people who have average risk, medium risk, 10 to 20%. And this whole group actually contribute to the burden of cardiovascular disease. And just to use lipids as an example, these are individuals who already have a coronary artery disease, has an event. You find that the people who have got high, very high LDL, actually only a small number. The majority of the patients who had coronary artery disease came from those who had less than 2.6 millimoles and even less than 3.4. So although we treat this group, this huge group of people continue to contribute to the burden of cardiovascular disease. And so therefore, we need to think of how we can identify this group who may benefit from treatment. So what is apparently like a medium risk based on the traditional risk factors may actually not be the true risk, and these individuals may be at higher risk. And this is when we need to consider other cardiovascular risk tools that are not used in the traditional factors in the risk tool calculation. We know that family history is associated with as much as 50% increase in cardiovascular risk. We know ethnicity, particularly in South Indians, have a greater risk. Obesity, Asians, lower level of BMI, we are more susceptible. And of course, many other lifestyle problems as well. There are also biological markers like albuminuria, HSCRP, amongst many others. But what has been found is that even if we did these in, say, a high-risk individual, it does not change the risk profile. The person is still high risk. And of course, it's not much point doing this because these are not readily available. They're expensive to do. if it doesn't change the risk classification or the category. However, we know now, of course, that chronic kidney disease is associated with increased risk. And so if we look at whether an individual, particularly in someone who has medium risk, whether using CKD to enhance identification and stratification of risk is useful. So what I did was we got hold of a cohort retrospectively who were free of cardiovascular events at baseline with a follow-up of 10 years, looking at the cardiovascular events. And what we see is at baseline, if the individual were classified as medium risk, the people who had chronic kidney disease, the percentage number of cardiovascular events is nearly 4 times that of someone who has no CKD. And so this is an instance where someone with medium risk, when you're not certain whether to treat or not, obviously look for TKD, which is readily available. You just need your serum creatinine to guide you on whether this patient actually has added risk. Other considerations, of course, will include, we have talked about this morning, about the impact of blood pressure on Asians, which is greater. I think Prof. Kario also touched on this about the morning surge in Asians, in this case it's Japanese, far greater than in Caucasians. And of course, again, data has shown that the morning surge is associated with target organ damage as well as cardiovascular events. Lastly, of course, arterial stiffness. Again, South Asians have been shown to have greater arterial stiffness than age-matched Europeans. And of course, the reason for looking at arterial stiffness is because it's an independent risk factor for a predictor of coronary heart disease and strokes. And in fact, the Framingham Heart Study in a more recent publication suggests that arterial stiffness could improve the risk stratification when added to the standard traditional risk factors. And finally, of course, blood pressure variability and whether one dips the blood pressure when we sleep or whether there's a rise, again, talked about this morning and also a little bit just now. These are also important considerations when trying to identify high-risk patients. So just to end and summarize, identification of high-risk patients is very important, particularly for primary prevention. And at times, we might need to use other risk factors to help to re-stratify, particularly those who are at medium risk, so that it then gives us a more rational and impetus to perhaps start treatment earlier rather than later. And of course, recognizing the fact that the impact of blood pressure on Asians is greater than that for the Caucasians. With that, thank you very much for your attention.
Okay, thank you, Chair, for the beautiful, integrated speech on the target organ damage, especially focusing in Asia. Is there any comments or questions from the audience? So, yes, please.
Nursing from Chennai, from
yes.
India. Yeah.
Yes,
yeah. I think I need to appreciate the projection made by Dr. Chia, and it's a wonderful presentation. It's better to identify people in whom you are looking for a primary prevention strategy, particularly people who are very obese, people with a metabolic syndrome is on the rise, particularly in India and South Asia. And we need to identify those individuals because those are the people who have mild elevation of blood pressure, 135, 85. After a period of 1 year, that goes to 145, 90. Like that, it goes on. I think if you catch those people at the younger age, when they are obese, when they have features of metabolic syndrome associated with the lipid abnormalities like high triglyceride, low HDL, increased proportion of small density LDL cholesterol with an increased ApoB content. It is not the LDL cholesterol that is very, very high in South Asians or in Indians. It is the triglyceride that is high, the low HDL is high, the small density LDL cholesterol which we don't measure, but we always concentrate on ApoB or the LDL levels, even if it is marginally raised in people with diabetes. We try to take that into consideration as the most important risk factor. I think
it's a time to short the discussion time. So we want to have another audience opinion. So is there any comments from the other?
May I have a question for you?
Mm-hmm. Yes, please.
Hi, Professor Chan, thank you for your elegant presentation. In our country, it is very difficult to define the high-risk patients, especially for the elderly, because that the age factor, when they are over 65, they will be almost automatically become a high-risk patients.
Yes.
So the target blood pressure for them will be automatically become less than 130. So this is the difference between the Framingham risk score between the Korean style risk scoring system. So what is your situation, or what is your situation in the other country for the risk of the elderly age factor that is too strong for our people in this country?
Sure. That's why I mentioned that if you use any of these, we know that the risk charts are heavily weighted by age. The age carries the most points. And so you're quite right, in the elderly, we have to be a bit careful. And this is where you need to validate the charts, the existing charts, because the existing charts give a value to the age, points to the different age. So therefore, there's no two ways about it. We probably just need to validate these in the elderly population. And of course, I think in China, they did the validation of the Framingham in China, a few groups of cohorts of people, also in the elderly, and found, of course, that it overestimated a little bit because the background risk of China at that time, when they did it, is actually very low, much lower than the Framingham background risk. So it will overestimate risk in an area that has got a low background risk.
Okay, thank you. So is there any comment?
Thank you.
Professor Cario, Dr. Min is rising hand.
Yes, please.
Yeah.
Dr. Min, please.
Yeah.
Okay,
thank you.
Comments?
It was very this morning very interesting to hear from the many presentation. And from the presentation concerning about the home BP of Dr. Yuan, I think this is a good initiation in the future. But you see, as in ESR, International Society of Hypertension guidelines, blood pressure and ABPM, it deserves for the optimal strategy for control hypertension, and especially right now in some countries, the number of the doctors who use the home BPs, for example, in Vietnam is under the 20%. So I think that this is a good recommendation. I can use to apply and motivate the doctor in the future to use this application. It can change the outcome of the hypertension in our country and even in our Asian countries. For the second, the presentation of the Professor Yuk Chia, it's very interesting. I think if you will evaluate the
okay, thank you, Dr. Min. So, or Professor Jimmy Teo, do you have any comments from the kidney side?
Yeah, so I think that you know, it's a very good initiative that we should work together to understand all the epidemiology and problems that we have in terms of blood pressure in Asia, and then to come up with appropriate medical evidence for interventions and also monitoring. So I think on an overall basis, we thank the organizers for getting all of us together to work on all these aspects of medical care that lacks a consensus and treatment protocols. So Professor Carrier, thank you very much for letting us participate in this.
Thank you. Professor Savrat from Pakistan, do you have any short comments? You are mute. Savrat, you are mute.
Yes, thank you. Thank you for asking. I appreciated Dr. Chea's last talk very much. But I think it's not easy, as he also gave 3 options of what you can do to make your own guidelines as to the risk profiling. It's not easy for us to do it on a massive scale. So we have to go with some guidelines which we can follow. I think the Indian guidelines mostly would be the ones which we can follow, because South Asians are quite similar in that respect. And I would be looking into those guidelines, I think, to see if we can implement them for assessing high risk. And some points have been mentioned by Dr. Rarasingan regarding metabolic syndrome. And I think that holds very much true, because if you look at the slide presented on the data from the Asian countries, our obesity rate and our diabetes rate is one of the highest in the world. So those point to the same thing. Thank you.
Thank you very much. Deborah from the Philippines, the short comments.
Yeah, thank you, Professor Carrier. Congratulations to all of the speakers and for getting us together. Anyway, we know that we have really risk factors here in Asia that is not really found in our European and American counterparts. So basically, with risk factor tools, I think for countries who don't really have the studies and the cohort studies that are available, I think it's very valuable that Professor Shia actually put to the table that we can validate tools and look at the background data of these tools. And we welcome any collaboration that this meeting will do, and rest assured that the Philippines will collaborate with everyone. Thank you.
Okay, thank you very much. We are closing this talk. So let's keep studying and making the evidence and keeping the discussion. And then finally reach the consensus. So thank you very much for, and also very sorry for cutting some of the discussions. So Professor Nishiyama, please, could you continue?
Thank you very much, Dr. Kario and Dr. Lucky, and everybody for very exciting discussion.
Yes.
Actually, I'm very sorry for the time limitation, but every discussion should be very important to propose the Asian consensus, I believe. So we can move on the today's main event, Okinawa Declaration. Thank you for waiting. Presenter of Okinawa Declaration is Professor Yusuke Oya, who is the president of the JSH annual meeting in Okinawa. So Professor Oya, are you ready?
Okay, I'm ready. The statement of the Asian Hypertension Society Network Okinawa Declaration. The Okinawa Island, located in East Asia, have a unique geographical location and have numerous histories as one of hubs for logistics and cultures in Asia since the age of exploration. At the time of the 43rd annual scientific meeting of the Japanese Society of Hypertension in Okinawa, we announced the Okinawa Declaration for the unity of hypertension societies in Asian countries and regions. Okay, so we hypertension societies in Asian countries and regions declare to collaborate to overcome hypertension and hypertension-related diseases, and will strive to create an Asian multidisciplinary network for the management of hypertension and hypertension-related diseases. Actively promote clinical and experimental investigators for hypertension research to encourage participation from researchers and practitioners from Asia. Share Asian evidence to promote the establishment of standardized management of hypertension in Asia. Continue to work toward developing Asian consensus guidance for the management of hypertension using a collaboration approach and taking into account diversity within Asia. So now we are organizing committee of 43rd annual scientific meeting of the Japanese Society and the Japanese Society of Hypertension and the Hope Asia Network and all the Asian Hypertension Society Network. All we now declare this statement. Thank you very much.
Great.
Thank you very much.
Thank you very much, everybody. So thank you very much, Professor Oya and Professor Rakugi. Dr. Oya, can you show the declaration paper one more time with Dr. Rakugi? Oh yeah, very good. Good. So thank you very much for everybody. Now I would like to ask all panelists to turn on the camera to take the screenshot picture. So could you please turn on the video for all panelists? Thank you. All right. So could you change to the audience mode, Secretary? Okay.
Yes,
Gallery
we are
mode.
taking the picture right now. Thank you very much.
Dr. Shin, can you yeah, thank you very much.
Smile.
Smile, yeah, smile. All right, thank you very much. Okay. Now we would like to ask for the cooperation of all countries in order to achieve the consensus on hypertension in Asia in the future. And to present it at the ISH 2022 Kyoto, I would like to call on Professor Hiroshi Ito, President of the ISH 2022. Professor Ito, if you please.
Thank you very much, everyone. I am very appreciate your active participants and also heated discussions. At the last, I would just briefly show you the overview of the ISH 2022. So the ISH 2022 will be held on October 12th to 16th in 2022 next year at Kyoto International Conference Center. And the theme of ISH 2022 is the wisdom for conquering hypertension. Although we do not know COVID situation at that time, we do want to hold the meeting on site. So I welcome to everybody to Japan with some aid of online contents, which can promote the participation of young researchers or students or the participants from the developing country who cannot come to Kyoto. Kyoto is the formal capital of Japan and full of Japanese cultures. And Kyoto has 17 UNESCO World Culture Heritage Sites, so you can enjoy a unique Japanese culture during your stay in ISH 2022. We prepare a travel grant for 300 young presenters and also poster awards for participants from developing countries, which covers Congress participation fee, travel, and staying. Also virtually, they are free of cost. And ISH 2022 is supported by various organizations, including the Science Council of Japan. It's a very prestigious organization in Japan. And so maybe the participation of imperial family is well expected. So we have three main topics. One is MOVE, that is exercise and fitness. Number two is food, that is food or nutrition. And number three is AI, artificial intelligence and digital health in relation to health, hypertension. Here are our program principal categories, which includes hypertension for SDGs towards 2030 or global health and hypertension with diversity, or life course and hypertension, super age society and hypertension. So hypertension next generation therapy and so on. So we expect many participants from the different fields, not only from the academic and medicals, but also from various companies and governments. And by sharing the multidisciplinary wisdom regarding hypertension and related disease, ISS 2022 should be the platform to create a new paradigm in preventing and treating hypertension. Here are scheduled special lecturers. Victor Zhao, Jay Zhao, he's my mentor. He's now president of the United States Medical National Academy of Medicine. Dr. Richard Lefton, he is the president of Rockefeller University. Dr. Hiro Imura, he is the president of Japan Academy. And also Dr. Shinya Yamanaka, he is the 2012 laureate of Nobel Prize in Physiology and Medicine, and he is a discoverer of course, iPS cells. So until ISH 2022, there are only less than a year, 363 days are left. So countdown event will be followed from today. We open official homepage and Twitters, so please get the latest information. We strongly hope your active participation and cooperation for the success of the meeting. Thank you very much.
Thank you very much, Professor Ito, for your wonderful presentation. Actually, we cannot wait the ISH 2022 Kyoto. So today, about 1 year before the date of ISH 2022, so I would like to start the countdown to ISH 2022 with my friends from all over the world today. So I have asked again Dr. Ito to give a special message as a countdown ceremony 1 year before the ISH. So he already prepared a special video to all of the audience. So please start the videotape.
Hello, everyone. Welcome to the countdown of ISH 2022 Kyoto Scientific Meeting. I am Hiroshi Ito, the president of ISH 2022 Kyoto. Now we are in New Japan Olympic Stadium. Tokyo Olympic Games 2020 were held here, but without any spectators. However, in ISH 2022, we do expect that every friends and colleagues from the world can come to Japan. The theme of ISH 2022 is the wisdom for conquering hypertension. We focus on 3 topics. Number 1 is food and nutrition. Number 2 is food, exercise and fitness. And number 3 is AI, artificial intelligence and digital health. Until ISH 2022 next year, less than 1 year is left. There are 363 days. So here, I want to count down with the members of my department. Everybody okay? Okay! 3, 6, 3. Welcome to Japan.
Thank you very much, Professor Ito. Even it is frame by frame images, but probably we can enjoy to start the countdown event from now. So from now, I'm looking forward to working with all of you on the countdown of the ISH 2022 together. So if you would like to join us, please send an email to me. Okay, today, finally, I would like to introduce Professor Hiromi Rakugi, President of the JSH, for giving us closing remarks. So Professor Rakugi, if you please.
Mute.
Thank you very much for Gishiyama, Professor Gishiyama, kind introduction to me. So I'd like to close this session so long time, 5 years, 5 hours, more than 5 hours. I'd like to share the slides. We representatives of hypertension societies from 14 Asian countries or regions have joined together today and have issued the Okinawa Declaration. And so, as declared in Okinawa Declaration, we will continue to develop Asian consensus guidance for managing hypertension together, using a collaboration approach and taking into account diversity within Asia. I'm confident that we will discuss these issues in greater depth at next year's ISH in Kyoto, so ISH 2022. Finally, once again, I'd like to thank everyone for organizing committees this special session today. Especially, I'd like to express sincere gratitude to Professor Oya and Professor Gishiyama. I'm looking forward to seeing you all face to face at the ISH 2022 in Kyoto next year. Thank you very much.
Thank you very much, Professor Rakugi. Today, Asian joint session has been closed. Thank you very much again for your kind participation. And probably, finally, you can turn on the videotape again, and we can take a screenshot together. Okay. So, all right, good. So, maybe we can see you in the near future in Kyoto 2022 ISH meeting. So thank you very much for your participation. Thank you. Bye-bye. Bye-bye.
Bye-bye.
Thank you.
Bye-bye.
Thank you, friends.